Sir, one person you should take care from there. One person needs to utilize and just
We have to do what we have to do.
one person you check them.
How it is coming or not happening. But
You
from here actually we can't.
commenting is
From here actually we can't do. No, hello.
ఏం చేయాలి చెప్పి మ్యూట్ చేసి స్ట్రింగ్ మానిటర్ చేస్తానంట అవుతుందా లేదా అవుతుంది ఇన్ బిట్వీన్ కామెంట్ చేస్తా ఉంటారు సంథింగ్ మ్యూట్ అన్మ్యూట్ అన్నట్టు రాజా
ఓ ఇలా సీట్ లగేనా
వీడియో లేదు కదా ఇప్పుడు ఇంకా ఇప్పుడు మేము
This is not needed, no? Then we will get there.
చేస్తాను
Come on.
రాజా सर
मेरे को नहीं पता मैं तो सुनता नहीं है वहाँ से जितने भी किए उसको भला करे जो मेरे को यहाँ बताया मेरा नाम याद है इसका भला करे मतलब आइडियली स्पीकिंग राइट साइड में होना चाहिए
हाँ मतलब तुम सही है ना ये
हाँ
हाँ
सर पूछा था
हाँ
सर यहाँ पे कौन है सॉल्यूशन आपके बाजू में कौन
हाँ नहीं ये जीपीएस दोनों बीच में
हाँ आज तो हमारी बात
कितने
నోట్లో ఉంది
मुझे होगा ना मास्क की वजह से आ रहा है चिराग समझ मैं इंस्पेक्टर में क्या वो तो इंस्ट्रूमेंट कौन से हमारे स्टूडेंट
ఇది ప్లే చేయాలి
नर्सिंग वालों को थोड़ा सा
ఇది ప్లే చేయాలి That's why I need to change the slide this one. No, slider. Translating the sound on this.
Come to नीचे नोटेशन है ना डिग्निटी नोटेशन नहीं
अच्छा ठीक है
Recording cloud outlet and Zoho recording is shared content also.
बहुत सारी चीजें नहीं ना पूरा आप उसमें से यहाँ फील्ड में कुछ
डॉक्टर सलीम हमारे
हाँ डॉक्टर सलीम मैम दे
Online.
और मैं
नीचे चेक
पावर बैंक सर पावर बैंक अरे पावर ये चल कौन है पावर बैंक का तो ये कौन चल रहा है क्लास बात प्रॉब्लम इस वाली पावर बैंक की नहीं है
It is slides.
Sir, yes.
My
Sir,
slides.
you are going to be your own
If the next बोलना पड़ेगा या मेरे more variant forward is this. This is back. This is the bottom. Okay.
Yes.
हाँ सर हाँ जी सर
People are waiting.
yes sir so you want to charge हाँ जी
Vishaka, ये felicitation of dignitaries is over. सीधा सर के
ठीक है सर जी सर
क्या felicitation वेब पे क्या करना है
लेकिन हम करेंगे
वो वेब बंद कर ले कैमरा बंद कर दे के लिए शो योर पंचुअलिटी
हाँ जी
वही
felicitations के लिए and I'm writing model letters and then I will present
सर इतना felicitation Man of the candidate कौन जाएगा? It's 6 or 8.
विकास सर एक आएंगे
हाँ कपिल क्या हुआ? हाँ अच्छा रीशेड्यूल नहीं हुई हाँ हाँ मैंने उसको अभी पूछता हूँ। अच्छा ठीक, I'll just tell you. हाँ मैं अभी बोलता हूँ, ठीक है, मैं अभी बोलता हूँ। हाँ ओके।
अगर आप साइड या बोलो
हाँ मलिक जी, मैंने इंडिगो से पता कर लिया, मेरे ट्रैवल एजेंट ने बोल दिया 340 वाली ऑपरेट कर रही है जैसे नहीं हुई अभी शेड्यूल 340 पे ही है, 340 पे है। हाँ तो इंडिगो नहीं हुई है वो किया है और वेबसाइट पे भी देख सकते हैं, ठीक है, ओके बाय।
सर ये बता में है ना, मेशो से यहाँ एक नहीं यहाँ के Yes.
A very good afternoon to one and all present here, and thank you for joining us for this CME. Before we begin, I would like to express my sincere appreciation to all those who contributed generously and helped us in organizing this event successfully. Firstly, I welcome our Chief Patron, our Chief Executive Director, Professor Dr. Vikas Bhatia sir, who offered wholehearted support for this CME. I welcome our co-patrons, our Dean, Professor Dr. Rahul Naran sir, our Medical Superintendent sir, Professor Neeraj Agarwal, and our Deputy Director Admin, Colonel S.P. Anant Rao sir. Today we recognize this day as World Hepatitis Day. This year's theme is Hepatitis Can't Wait. With a person dying every 30 seconds from a hepatitis-related illness, even in the current COVID-19 crisis, we really can't wait to act on viral hepatitis. We are proud to announce today that the chief guest for this CME is Dr. Yogesh Chawla, ex-director PGIMER, Chandigarh. I warmly welcome you, sir. We are really honored. Guest of honor, Dr. S. Sarin, Director, Institute of Liver and Biliary Cirrhosis. And guest speakers, Dr. Pradeep Deshmukh sir, the Dean Research, Community Medicine, AIIMS Nagpur. Dr. Bhupe Varman, Associate Professor Medicine, NEIGRIMS Shillong. Dr. Sahaj Rati, Assistant Professor PGIMER, and Dr. Shilpa Thummer, Scientist, National Institute of Virology. I welcome you all. We are proud to be able to host it today here at this wonderful place with all of you. Well, I don't want to take much of your time. I welcome all the dignitaries. and I welcome our Director Sir for inaugural address. I welcome all the dignitaries for lab lighting.
Madam, Mustafa,
I warmly welcome our Director Sir for inaugural address.
Good afternoon, namaskar. My great pleasure to extend a very, very warm welcome to everyone. It's my great pleasure that on behalf of the Institute, AIIMS Bibinagar, Hyderabad, Professor Chawla has come from Chandigarh, graced this occasion as chief guest. On the occasion of the World Hepatitis Day, which we are celebrating at our institute for the first time because we are in very early stages of establishing this institute. I also welcome and express my thanks to Professor Sareen, Director, Institute of Liver and Biliary Sciences, New Delhi, India, Dr. Pradeep Deshmukh, and all the resource persons and participants who are connected with us from different parts of the country online, and our in-house colleagues, Dean Professor Rahul Narang, Medical Superintendent Dr. Neeraj, our organizing team, Dr. Vishakha Jain, and Dr. Lakshmi, and all the this team has worked day and night for last 1 month when they came to me and talked about celebrating this occasion. 2 departments have joined hand on this occasion. In addition to some other departments who are passively or indirectly extending their full support on a particular disease which does not belong to one department. In order to win over this, we all need to work together. We have we have 2 leading hepatologists of the country of India. Dr. Chawla, who has spent his entire life as a hepatologist at VGI Chandigarh. He has done so much of work in this field, and also Dr. Sareen, who is the director at there is an institute specifically working on livers. Department of Microbiology at our institute and medicine, they decided that we should work together and see that how best we can reduce this and how we can plan, because in this new institute, if we start working in a collaboration within the house and outside, I don't have the doubt that we'll be able to overcome this. This is the era of viral diseases. COVID is already troubling us, and we are already facing the problem in last 15-16 months. Now we have been another virus which have been troubling us for many decades. That is the hepatitis. Now we have a big range. We hear about mutation, this Delta virus, COVID, this, that. We know A, B, C, D, E, hepatitis, and any possible mode of transmission. If we see the epidemiology and the mode of transmission, whether it is a waterborne, it is a needle prick injury, or it is oral consumption, or so many ways the disease can affect the human beings. So it is the multiple approach which is needed to overcome this. We need to see that the hospitals, they follow the universal precautions. Staff is protected from the needle pricks and from the blood transfusions. We have all the precautions. The immunization on hepatitis has been made part of the immunization program now. It's a national program, hepatitis B, and in many private sector, even the hepatitis A vaccine is also, because of the cost, it is being taken. So these all, plus the other preventive measures, even the Swachhta Abhiyan of the Government of India, which is a flagship program, will be of great help in providing safe drinking water. So many measures will help in preventing the disease, but at the same time, this disease is so rampant, and when we have a plan to bring it down to a status, a level where it is no more a public health disease, and we don't have enough time as far as the goal is concerned. I think it is 2030, and we do not have many years ahead, whereas our time and our resources are also being shared with the COVID management. But I'm very sure that when we have a strong team of professionals and paramedics, nurses, doctors, and our leading professionals like Dr. Chawla and Dr. Serene and various other institutions, we will be able to manage this in near future. With these words, I congratulate the team of the medicine and microbiology for organizing this event and hepatitis B mitigation and working towards elimination. So many diseases we talk about eradication, but short of that, we start with the below that is the elimination, and below that is the control, and below that is what we need to prevent. So one day we hope we are able to finish these two viruses, hepatitis and COVID, whether they go together or one after another one. So we should be very alert and careful that our biology department, which microbiology should also be looking after very carefully now, we need to keep an eye on various viruses. Thank you, sir, for coming. Thank you, everybody.
Thank you, sir. Now, introduction to the team of World Hepatitis Day and CME. I invite Dr. Rahul Narang sir to come and present.
Thank you, Dr. Lakshmi. Honorable guest, Dr. Yogesh Chawla ji. Director, Dr. Vikas Bhatia. Medical Superintendent, Dr. Neeraj Agarwal. Dr. Serene, Dr. Pradeep Deshmukh, and other speakers, and my dear friends. So I have been given this responsibility to introduce the theme of today's World Hepatitis Day and to explain the theme of this CME, that is Hepatitis B Mitigation and Working Towards Elimination. So I'll explain this theme on the basis of 2 points. One I call silence of foundation stones, and the second one, a sense of inclusiveness. But before that, I wish to reiterate the words of Director General of WHO, which he spoke on 21st, explaining this theme. And I quote, he says that on 28th of July, we will observe World Hepatitis Day. And this day, he says that it's like the hepatitis will not wait and the clock for us is ticking. Clock is ticking because presently we have more than 150 million chronic cases of hepatitis, and 80% of these people cannot have access to treatment and cure. More than 3,000 deaths, they occur in one day because of cirrhosis and malignancy. And 2016 to 30 goal states that we should reduce new infections of hepatitis B and C by more than 90% and death by more than 65%. Unquote. So, all this, how it has to be done, our people who are involved directly in this program, Government of India is also running this program. They are to be congratulated for this. But then, while we say we observe this day, whether we celebrate this day or we mourn this day, that depends upon to whom we are talking about. So while the families and we mourn the people who die because of hepatitis B every day, and those who we empathize with those who suffer silently in their homes while suffering from the disease, waiting for treatment and care. We celebrate this day for countless people who are working tirelessly day and night, whether in the laboratories, translational research, public health, community level, everybody together who is working towards the elimination of hepatitis B in coming years. The theme for today's CME is hepatitis B, and I know all the experts will talk about this, the epidemiology, the diagnostic aspects, clinical features, prevention and cure. But then we should also talk about something which is very dear to my heart and should be discussed at such fora, is hepatitis E. Hepatitis E is transmitted from animals to humans, it's a zoonotic disease. Although we can take care of hepatitis B by treatment as well as by vaccination, the measures for hepatitis B will be very simple, but then all of us, whether in the human health or animal health, environmentalists, we have to come together and work in unison to eliminate that other disease also, so that the world is free from hepatitis as such, all the 5 viruses. And this is what I call essence of inclusiveness. So I congratulate the organizing team for organizing the CME and all the participants who are enjoying this academic feast. Thank you very much.
Without much ado, it's a great honor to introduce Professor Yogesh Chawla, our chief guest for today's CME. So we are humbled that you've accepted our invitation to preside as chief guest for our CME. Professor Yogesh Kumar Chawla is a Padma Shri and BCA Roy Award recipient. He was a former director of PGI Chandigarh and former head department of Hepatology PGI Chandigarh. At present, Sir chairs the academics as Professor Emeritus at Kalinga Institute of Medical Sciences, AIIMS Bhubaneswar, and is member of the Institute body at AIIMS Bhubaneswar. We are fortunate today to listen to his 37 years of distilled experience in the field of hepatology, with numerous publications, chapters, and books, in accordance with his special interest in liver transplantation, acute liver failure, and acute and chronic liver failure. Now, I would like to invite our chief guest, Professor Yogesh Kumar Chawla, to come over to the podium to deliver his keynote address.
Thank you, Dr. Vishakha. Thank you, Dr. Vikas Bhatia, for inviting me for this talk. The background has already been given by Professor Rahul Naran, and we are all familiar with the hepatitis B and hepatitis C and its problems. But are we able to eliminate hepatitis B by 2030, as has been said by WHO? Let's look at what are the possibilities. Hepatitis B, you all know, is a DNA virus. It replicates very rapidly, undergoes mutation, and once a person is infected, he passes on through 5 stages like immune tolerance, immune activation, low replication, reactivation, and remission. And all these stages have different viral replicative statuses, different viral antigen expression, and inflammatory activity of the liver. So whenever an individual gets hepatitis B infection, he passes through a phase of acute hepatitis. If it remains unnoticed, he goes into a phase of chronic hepatitis, which may take years. Further, he may go into cirrhosis if he still remains undetected and untreated. And finally, these patients develop hepatocellular carcinoma. So, it's important that we halt the progression of hepatitis B from the stage of acute hepatitis or at the stage of chronic hepatitis by diagnosing and treating these patients. So, transmission of hepatitis B is either vertical from mother to child. In India, it's about 50%. And it could be horizontal through percutaneous routes like blood transfusion, which has not been adequately tested, infected blood and body fluids, infected needles, what we see with intravenous drug abusers, or it could be a sexual transmission. When we look at the prevalence of hepatitis B in the general population, it ranges between 1% to 12%. Average is about 3 to 4%. Worldwide, there are 292 million cases of hepatitis B and about 58 million are occurred. That means they would be surface antigen negative and still be harboring hepatitis B infection. And huge number of deaths occur every year because of hepatitis B. When you look at the Indian statistics, about 48 million hepatitis B individuals are there. 10 to 20% of these people would go into cirrhosis in 5 to 15 years. In most of the liver centers, 40% of HCCs are because of hepatitis B and 20% of cirrhosis are because of hepatitis B, preceded by alcohol, non-alcoholic fatty liver disease, and these cirrhotics may develop hepatocellular carcinoma later. So it takes about 5 to 20 years for an individual after getting infection to go into the stages of cirrhosis and hepatocellular carcinoma. And if there are comorbidities or if the person is consuming alcohol, has evidence of fatty liver disease, hepatitis C infection or HIV, the progress is faster because two agents are damaging the liver. Hepatitis B is the 7th largest cause of mortality, and by the year 2040, it is likely to exceed the combined mortality of HIV, malaria, and tuberculosis. So, looking at these statistics, it is a major public health problem. One of the problems with chronic hepatitis, both B and C, is majority of patients are asymptomatic. That is why they are called as silent killers. And only a small proportion of them are symptomatic. by way of developing jaundice, upper GI bleed, hepatic encephalopathy. Chronicity happens if hepatitis B infection occur in neonates in 90% of individuals. If hepatitis B occurs or is given in early childhood, 50% of them chronicity. But in adults, if acute infection occurs, only 5% turn out to be chronic. So how do you diagnose hepatitis B infection? Most important is surface antigen. If he's HBsAg positive, he is an individual with chronic hepatitis. Then you should investigate him for E antigen. That tells you whether it's a replicating virus or not. And what is very important for treatment is the level of Hpv Dna quantification. We have different genotypes. In India, it's genotype A and D, which is slightly easier to treat and has less consequences as compared to genotype B and C. Liver functions, of course, need to be done. You have to rule out diabetes by doing hemoglobin A1C. Look at hepatitis C, there is evidence of co-infection. Hemogram is absolutely important because platelet counts tell you the amount of fibrosis which is there in these patients. It's also important to know by way of non-invasive fibrosis score, and that you do by way of FIB4, where you take into account age, platelets, and AST levels, or APRI, where AST and platelet counts ratios give you an idea whether the patient has evidence of fibrosis or he doesn't have any evidence of fibrosis. Ultrasound is a very rough way of finding out the fibrosis, but unless the patient has evidence of cirrhosis. And you should always do alpha-fetoprotein or PIVCA, which are tumor markers for ruling out HCC, since this is one disease which is responsible for developing HCC. So what would be the cascade of care? You should ideally screen patients, make a diagnosis, and link it to care after assessing liver disease severity, because the treatment is lifelong and it has to be monitored. And this is where the problem arises. Attrition tends to occur and patients do not take the medicines for lifelong. So I've mentioned that there are no cures as such as against hepatitis C, which initially was thought to be a controllable disease, but now with the availability of sofosbuvir and velpatasvir, you can say that hepatitis C is curable. Unfortunately, hepatitis B is still not curable, and especially patients who become E antigen negative or are in a low replicative phase, they continue to have chronic inflammation and are candidates for developing cirrhosis. So how do you define hepatitis B virus cure? Complete cure would be if on treatment, person becomes undetectable for HBsAg, develops antibodies to surface antigen, and has no evidence of CCC DNA and integrated DNA in the hepatocytes. This is something which is impossible to achieve as of now. What we try to manage is the functional cure, where you have undetectable Hpv DNA, and in a small percentage of cases, antibodies to surface antigen occur. That means there is seroconversion, but there are always low amounts of CCC DNA and DNA integration. So we get functional cure in a very small percentage of cases. It is basically partial cure that we do, and these patients tend to have reactivation or they relapse whenever they are immunosuppressed, like following chemotherapy agents. And the Hpv DNA, which was negative, shoots up to very high levels. Hence, it is not possible to eradicate hepatitis B virus. It is because of the CCC DNA, which is a mini chromosome reservoir, and it becomes very difficult. None of the drugs which are available tend to act over CCC DNA. And certainly the integrated Hpv DNA, which happens whenever a person gets hepatitis B infection, whether in the acute phase or chronic phase, integration usually takes place in these patients. And it's very difficult to find out whether integration has happened or not. There are no tests to tell us about that. So whatever treatment we give for hepatitis B, our aim is usually to make Hpv DNA. And if we are lucky, very small percentage of patients become surface antigen negative. If we achieve normalization of SGOT, SGPT, it is something very good. It indicates that the inflammation has decreased. And with the drugs available with us, you can decrease the risk of cirrhosis, decompensation, and hepatocellular carcinoma. Unlike HCV, which I just mentioned, the direct-acting antivirals, they wonderfully act in hepatitis C. Hence, lifelong treatment, since we are not able to tackle cccDNA, the hepatitis B is only suppressed, but we are not able to clear cccDNA. And what are the two drugs that are available for us? Interferon and pegylated interferon, which was very popular about 10 to 15 years ago. It had little amount of antiviral activities, but mainly was an immunomodulator. And the lethargic NK cells and T cells used to get activated with this. And when you give it for a period of 1 year with lot of side effects, one could achieve surface antigen clearance only in 3 to 8%. On the other hand, nucleoside analogs have to be given for a very long time because they tend to decrease the replication but have no effect on the other aspects of hepatitis B. And we are all familiar with tenofovir. Now you have tenofovir alafenamide, which has less amount of bone and renal toxicity. And the other drug is entecavir. Fortunately, both these drugs have very low resistance, hence mutation is not a major problem with either. So, looking at the problem of hepatitis B, the World Health Assembly in 2014 thought that there should be a strategy for eliminating hepatitis B. The Government of India in 2018 formed a national viral hepatitis control program because India also committed to achieve the sustained development goals of eradicating hepatitis B by 2030 and also end epidemics of TB, AIDS, malaria, and tropical and communicable diseases. So as was said earlier by the director here, you call elimination of a virus if you decrease the incidence by 90% and 80% of these individuals are treated and you decrease the death rate by 65%. In comparison to eradication, where there is a permanent reduction of hepatitis B. Unfortunately, our statistics are very poor, so also in many other countries. We don't have information on hepatitis-related deaths, which are usually underestimated, as we have seen with COVID as well. There are some important differences between hepatitis C and B elimination, and as I said, it's much easier to eliminate hepatitis C as compared to hepatitis B because excellent drugs that are available. So what was the objective of this National Viral Hepatitis Control Program? Firstly, to enhance community awareness, provide early diagnosis and management, establish simplified diagnostic and treatment protocols, strengthen existing infrastructure facilities, build capacity of human resources and raise additional human resources. Link hepatitis B control with the existing national programs of TB, HIV and non-communicable diseases. Increase the use of digital viral hepatitis information and management. Do free screening, diagnosis, treatment, counseling and do a lot of innovations. And increase the birth dose vaccination coverage and perinatal coverage. And this, the government said, would be through the primary public health facilities, which were designated as treatment sites. Then referrals for a little more complicated cases was done in district hospitals, and even more complicated cases should be tackled by medical colleges and tertiary centers by hepatologists and gastroenterologists at centers where Doppler, CT and MRI is available. Problem usually occurs when you have variants of regimen required. If a person has malignancy and has to be given chemotherapy, very often there is reactivation of hepatitis B. If there is a virological failure, that means you have treated these patients and suddenly there is a relapse. If these patients have acute liver failure because of hepatitis B and other important conditions. So you have to engage the community to increase and ensure and tell them that adherence to treatment once you are diagnosed is very important. It's important to have a good infrastructure, not only of space but of human resources. You have to do capacity building and training through e-learning, have a good viral hepatitis information management system, which is now in position at a number of centers. Finance is important. You should have review meetings and supervisory visits and evaluation. So these were the guidelines which had been set by the Government of India. Some of them have been followed, but with COVID being there, some diversion has happened in the elimination of hepatitis B. So what are the challenges in elimination? Only 10% of individuals know their illness, and very few of these 10% are being treated. So a major challenge is finding out the missing millions. So this is a global issue. Unless you test everyone, you're bound to miss a lot of hepatitis B cases. So to start with, high-risk groups like intravenous drug abusers, those on dialysis, hemophiliacs, thalassemics who repeatedly require blood transfusions. So these patients have to be tested. But then if you're tackling only the high risk, you're likely to bring about micro-elimination. But the major idea is to do elimination of the entire hepatitis B, which is a very, very big challenge. Moreover, selection of patients by way of guidelines which are available, they are not very straightforward and they are quite confusing. So the guidelines which are available now with us, including the Indian, Asian Pacific, European and American Association for Study of It, do not stress on elimination as of now. They still say that unless you have a DNA level of this much, you should not treat these patients below that. So this is a challenge which needs to be changed by hepatologists. You should screen all pregnant women for hepatitis B and start treatment if Hpv DNA is more than 2 raised to the power of 10^6 logs. So this has been studied in China. The model is that when you start vaccinating after screening, when you start treating these pregnant females in the 3rd trimester with the antivirals that I just mentioned, it is possible to bring down the surface antigen positivity significantly, as has been Chinese, Taiwan, Korean models. This is just a Chinese study. One should promote institutional delivery, and as I said, high-risk groups need to be vaccinated and looked at if they are hepatitis B surface antigen negative. Post-vaccination monitoring is important, which means you should do antibody tests in those who have been vaccinated, especially the high-risk individuals. And catch-up vaccination for children who have not been vaccinated, and close relatives of index patients, they all need to be vaccinated, which you would all agree is a major challenge. So you should at least to start with implement micro-elimination strategies to boost the national elimination effect. Surveillance is very important. We need to have simpler tests, like in clinical practice. After being surface antigen positive, you have to do Hpv DNA, which is costly. You don't have to do genotype. So now point of care tests should be freely available. Unfortunately, they are not widely done in our country because of the standardization and their sensitivity. So it all looks that, except for 3 countries who are doing extremely well and would be able to achieve the target of HPV elimination by 2030, possibly by 2050, the other countries also would catch up. So you should simplify the guidelines to diagnose and treat patients with hepatitis B. A little information about what are point of care tests. These are rapid diagnostic tests which require a very small amount of blood or a tissue or a swab. It has a very short turnaround time. It gives you a report in half an hour to 45 minutes. So much so, not only for surface antigen positivity, but even Hpv Dna. They are very easy to use. They require very minimum training. You don't need technicians for that. It can be done by anyone. It's like the blood glucose strips or urinary sugar strips. It would be more acceptable in the remote areas, community and outreach setups, useful in harm reduction programs, affordable, user-friendly, robust, and no significant equipment requiring power is not required. But the only disadvantage is its lower accuracy. And now you have point of care tests for hepatitis B surface antigen, antibody, Hpv DNA. All these tests would give results in 1 hour as compared to the routine tests which take about 4 to 6 hours if you're looking for Hpv Dna, which is an essentiality for starting treatment. And they are low cost. And just to keep you informed that there are newer tests available like Hpv RNA, hepatitis B core antigen, and these tend to correlate very well with cccDNA, which is covalently complex circular DNA. There is a lot of work going on the newer drugs so that an effective cure would be tried. At the site of entry of hepatitis B into the hepatocytes, there are inhibitors. One of the drugs which are likely to come up in the future is bulevirtide. Then cccDNA inactivators. These are still in the experimental stage. Capsid assembly modifiers, surface antigen secretion inhibitors, ribonuclease inhibitors, and immunomodulating agents with therapeutic vaccines. These are still in the phase 1 or phase 2 trials and still would take a few years before they come into the market. And this is a diagram which shows you the hepatocyte that enters into the virus which enters through the NTCP receptors, and you block the entry at these receptors. And there are other mechanisms by which hepatitis B can be cured. Unfortunately, it is not possible. You have to do capacity building of the healthcare workers because there is unawareness amongst a lot of healthcare workers. Doctors are very well familiar with it, but the nursing and the other laboratory technicians do not know much about hepatitis B and hepatitis C. And they are likely to be sources of infection, transmitting to the family and community. So it's very important to update them and train these healthcare workers, as has been done in a study recently published, where with 1 day training, the knowledge was significantly increased in more than 5,000 healthcare workers. So what could be the preventive strategies of hepatitis B? Apart from awareness and education of the individuals, there should be a birth dose immunization, which unfortunately, even when in well-developed countries, is possible only in 39% of cases. Only in 39% of cases in the Western world where birth dose immunization is. I'm sure it is much less in India. Then there are vaccines where to improve adherence, the usual dose regimen is 0, 1, 2 and 6 for children, or 0, 1 and 6 months. But there are vaccines now where only 2 doses is enough, 0 and 1 month, so that the adherence of the second dose of vaccination and protection is there. So if this could be integrated or started, this again would be of some benefit. Safety of blood and blood products, although it is being done very well all over the country, but I'm sure there would be many other centers, small centers in villages or district hospitals where safety is questionable. And the syringes, like the disposable syringes, should be now replaced by reuse prevention syringes, because at an average, about 2.9 injections an individual every year, especially in the villages, gets an injection, and almost 50 to 60% of these injections are unsafe. There should be a political will in the country. The government is very keen to have this hepatitis B elimination. It was COVID that diverted the attention. There should be advocacy. There is also a stigma involved with hepatitis B infection. So that stigma should be reduced. A lot of investments are needed, nationally as well as from the global levels, for sustainability. The management has to be updated, because with newer therapies, the guidelines keep on changing. But as of now, these guidelines are complex, and treatment is not recommended in all, especially immunotolerance individuals who have normal enzymes. Histologically, they do not have any significant liver inflammation or fibrosis, but they have very high Hpv Dna levels. Why should they not be treated with antivirals and the levels brought down? Because they can be a source of transmission if you have to achieve elimination. Integrate universal health coverage, improve the surveillance, identify other national activities, share the costs of hepatitis B as well, and increasingly use digital health as a way. So COVID has shifted the focus from hepatitis B control to the pandemic. Funding has been affected. Training and approach to healthcare workers for hepatitis B has been shifted. And one of the possibilities that has been suggested is integrate COVID-19 activities with hepatitis B program. If you look at the Taiwan model, it had a very high hepatitis B surface antigen prevalence, 15 to 20%. But the government way back in 1986 started at birth vaccination, started giving nationwide reimbursement program for drugs. And they have significantly brought down the hepatitis B infection rate. Hepatocellular carcinomas in small children was quite high. That has reduced significantly. This was all because of the governmental determination, good funding, and implementation of the vaccine program. So, after having gone through this, there was a recent article which was published whether it is feasible to eliminate hepatitis B. And some leading hepatologists of the world just about 2-3 months ago published that the Andrea Cox said it's highly unlikely. And 67% of the countries are unlikely to eliminate by 2030. Hepatitis B certainly is less likely, and hepatitis C may be possible, but since there is no vaccine available for hepatitis C, that also is a big challenge. The other hepatologist says that investment needs to be increased. Unfortunately, there is very little investment for hepatitis B elimination. This person, Kao from Korea, says that it's a very ambitious task. And when a survey was sent to 194 member countries, only 70% of them responded. 62% of them had a national plan, dedicated funding, and engaged with civil societies. And almost conclusion that he drew was 80% of countries were still not on track for elimination. The others said that there is a diagnostic burnout. Easy to reach people could be treated and tested for hepatitis B. But what about the marginalized societies, like those who are homeless, intravenous drug abusers, or those who are left out or poor? And they say that only 11 countries are on track. Another expert says it's very unlikely, even in high-income countries, because lots of hepatitis B are still undiagnosed. Analog says funding is a major problem, and COVID pandemic has diverted all the attention. So they say that it's impossible for us to eliminate hepatitis B by 2030. A little bit, just one slide for hepatitis C elimination, because we at PGI and in Punjab started this program of hepatitis C elimination way back in 2015. And since the availability of drugs that could cure hepatitis C, this involves a treatment of only 8 to 12 weeks as compared to hepatitis B, which has to be given lifelong. And you have pan-genotypic drugs, generics are available, which has significantly brought down the cost of these drugs. Hence, the government of Punjab and now the government of India has taken up this challenge. And through digital health and telemonitoring, we could, in the 22 districts of Punjab, we could manage to treat almost 50,000 hepatitis C patients or even more with excellent results. The number of diagnostic tests which are required to treat hepatitis C also were reduced. Just before HCV RNA, once you are anti-HCV positive, the standard guidelines say that you should do HCV RNA after 1 month of therapy, 3 months of therapy, and 3 months after stopping of therapy. We brought down the diagnostic tests from the start of therapy till 3 months after the stoppage of therapy, because 95 to 98% of these patients got treated or cured of hepatitis C. So friends, in conclusion, I would say that hepatitis B virus is an important public health disease. Consequences are grave. It affects the health economy by way of managing cirrhosis, HCC, and these patients have to undergo liver transplantation, which is all a very costly affair. The challenge for hepatitis B virus elimination by 2030 is very, very difficult. You need more investments. The guidelines need to be simplified. You need to bring out the newer hepatitis B virus medicines, which would help in curing the disease. Cheaper point-of-care diagnostic tests should be more widely available, and there should be increased awareness, again through the World Hepatitis Day, of awareness of the public. I see in a lot of newspapers, they carry a full supplement page on hepatitis B, and the healthcare workers need to be trained. So thank you very much for your attention, and we hope that we work towards elimination of hepatitis B and C in a very energetic way. Thank you very much.
Thank you, sir, for such an informative and insightful talk. And I'm sure that the concerted efforts of all stakeholders, we may reach at least somewhere regarding the elimination by 2030. Are there any questions for sir at present? Pending questions or in the audience?
Still now there is.
I request all the delegates, if there are questions, you can please type it in the chat box and we can answer them later in the sessions. I would like to request our Executive Director, Dr. Vikas Bhatia, to felicitate our Chief Guest for his presence here and delivering such an important talk.
Now, it is.
CME. It's a proud privilege to have Professor Shivkumar Saleen as a guest of honor. So thank you for gracing our CME with your august presence. Saleen is a senior professor, hepatology and director, Institute of Liver and Biliary Sciences, New Delhi. He was instrumental in setting up ILBS under the auspices of Government of Delhi. He is also the director of WHO Collaborative Center on Chronic Liver Diseases and Viral Hepatitis at ILBS. He serves as an adjunct faculty, molecular medicine at JNU, due to his deep interest and contributions to translational science. To his credit, he has several new treatment protocols for liver diseases, varicose breed liver generation, hepatitis B, acute and chronic liver failure. He has more than 670 publications, edited 13 books on liver diseases, and contributed 87 chapters. He has helped develop 19 major guidelines, out of which 6 are major Asian Pacific treatment guidelines in liver disease. Professor Shivkumar Saleen has been awarded numerous awards, among which are the prestigious Henry Lee Bogus Medal in 2017 by World Gastroenterology Organization. He's been given Padma Bhushan by Government of India. He's also the recipient of Shanti Swarup Bhatnagar Award by the World Academy of Medical Sciences, the ESN International Recognition Award, Om Prakash Bhasin Award, Dhanvantri Award, Ranbaxy Medical Science Award, Best Teacher Award. And he's also the founding editor of Hepatology International. Sir, I request you for your keynote oration. Slide show. आप बोलिए मुझे ऑडियो
अनम्यूट करने के लिए यहाँ पे बोलो just tell it.
Sir, can you please unmute yourself?
Sarin sir, you can unmute, sir.
We are unable to hear you, sir. मैम म्यूट पे है सर और स्लाइड्स को प्रेजेंटेशन मोड हाँ म्यूट पे है सर म्यूट पे है और प्रेजेंटेशन मोड में कर दीजिए मैम स्लाइड हाँ जी
Can you hear me?
Yes, sir.
Yes, sir. Now we can hear
And-
you, sir.
Yes, sir.
Hello.
Yes, sir. We can hear you, sir.
And the slides are also visible?
Sir, the slides are visible. Can I request you to take it on the presentation mode, sir?
Full screen, sir.
Yes, sir. Thank
Okay.
you, sir.
Is that all right now?
Yes, sir.
Okay. Good afternoon, everyone, and thanks, Dr. Vikas, Dr. Narang, Dr. Agrawal, and the organizing team from Hyderabad, the Bibinagar AIMS, and thanks to my very dear friend, Dr. Chawla, for making me part of this very important journey. I know you are trying to shape up the AIMS Bibinagar, and I can assure all the people there that they are with a very, very dynamic, very visionary person with Professor Chawla. I have known him for years, and therefore I can say this with real confidence. I bring greetings from the Institute of Liver and Biliary Sciences to also I want to give good wishes to Dr. Bhatia and his team. I have nothing to disclose except that we have young and bright faculty and brighter residents who place ILBS next to AIMS Delhi. I'll briefly touch upon this very difficult topic which I had to prepare, especially for this presentation of this day. Prevalence, the changing trends, what you think was yesterday, has it changed today? The data which we had collected from 8 countries over up to 2016 or so. These are liver-related deaths in Asia. You will see red, which is hepatitis B, and light blue is hepatitis C. They make about 50% of deaths, all deaths. Now, cirrhosis-related deaths per country-wise, India still gives you 50% and hepatitis C about another 10 to 15%. The liver cancer related deaths also you would see India would be about 50% like any other country. However, all this data was published based on what was on this surveys till 2015 or 16. Subsequently, we conducted another survey. This is an analysis of ILBS along with 9 or 10 other WHO collaborative centers. What are the etiological factors of cirrhosis and liver cancer in India? So this is updated till June 21. Of about 3,200 patients, of which majority had cirrhosis or cirrhosis with HCC. These are the different centers: Ludhiana, PGI, Bombay, LTMMC, Mumbai, Vellore, AIG Hyderabad, and others. And I hope we will add AIMS Hyderabad soon. So we will have demography, 54 years, majority were men. Now, this is the survey by and large from 15 to 20. You can see alcohol is on the rise, diabetes on the rise, and Hep B and C make just about 30% of the total cases. While in the previous study, I showed you close to 50% or more. Now, this is a data which shows you from the ARC countries. ARC is the APSL, ACLF Research Consortium. This is acute on chronic liver failure, where we want to know what is the basic underlying liver disease over which there is a liver failure. Now, this is 2010, 11 to 15, and 16 to 20. You can see alcohol has gradually increased, while viral, which was the major cause, has gradually decreased. And other causes also, like NASH and cryptogenic, they have also increased. So there is of patients coming as chronic liver disease. In 2001, hepatitis B was 3/4 of the cases. The trends have changed. Now, when you see the liver cancer patients, you will see hepatitis B and C put together will make close to 45% or 47% or so, while diabetes and alcohol would make close to 50%. This was not the case. And so diabetes is a liver disease and it is a cause of liver cancer is becoming clear. So alcohol and diabetes are now overtaking hepatitis B and C put together. Now, if the patient has underlying cirrhosis, then hepatitis B and diabetes are the commonest. This is a cirrhotic liver where cancer develops. Here is a liver cancer without underlying cirrhosis. So non-cirrhotic HCC. Here you will see again diabetes makes nearly 50%. So what is the message? The message is both in cirrhotic and non-cirrhotics, metabolic liver diseases are overtaking the viral infective diseases. However, this doesn't undermine that B and C can be ignored. They still make a chunk of 40% or so of our diseases. So can the ILBS WHO collaborative study help? Yes. All over India, we need to relook what are the attributable fractions of hepatitis B and C towards development of cirrhosis and cancer. proportion of alcohol and diabetes. If you notice these trends, are they increasing, stabilizing, or decreasing? And we have to aim to decrease them. We have to help target susceptible populations at all community levels, change diagnostic and interventional strategies. And of course, I would like Hames Bibinagar to kindly help and educate us what is the pattern in the South. Now, some issues which relate to the topic of hepatitis B and liver transplant. I'm not covering acute viral, I'm just covering some B and C. Now, compensated cirrhosis becomes decompensated, means ascites, jaundice, bleed, or encephalopathy develops in about 5 to 7% per year. But this is cumulative. They survive about 12 years or more. Once decompensated, then the 2 year is the survival. So we have to start thinking when they become decompensated for transplant. The indication, this is very broad. You have to consider in a decompensated end-stage liver disease, why you want to transplant. Yes, I can extend the life beyond predicted. Let's say cirrhosis lives 12 years. Will you transplant every cirrhotic? No way. You will transplant a decompensated? Yes, because he may die in 2 years' time. So I need to give transplant and he can live for 10 years or more. I have to improve the quality of life. It doesn't have to go to hospital every 2-3 months. Now select that if the patient has surviving less than 1 year without a liver transplant, he needs a transplant. And the quality of life that he is living is not acceptable. So I need to give him good quality of life. These are the two basic premises for consideration for liver transplant. Now, hepatitis B. Earlier, a patient with hepatitis B would get a donor liver, deceased or living. The virus will get into the person from the recipient into the new liver. So what they would give, hepatitis B immunoglobulin was given. And this had reduced the failure of the graft from 80% much lower. Without a HBIG would neutralize the virus. It will adsorb the hepatitis B virus and the antibody will adsorb it. After HBIG, graft failure decreased to 30%, but it's very expensive. So then in 90s, nucleoside analog entecavir, tenofovir came, and the graft failure has become to less than 10% or so. So this is the shifting paradigm. Earlier in 90s, lamivudine came, but at that time HBIG, 10,000 units, so then lower dose of HBIG came. Then limited duration of antibody, and then newer drugs came, nucleoside analogs, entecavir, tenofovir. Now, by and large, HBIG-free regimens have come. Means your patient prior to transplant is given antiviral. If he gets the transplant, you can continue the virus-related drugs. Let's see this. So, before and after transplant, the viral activity DNA was present. After transplant, for several months or even years, sometimes DNA may live in monocytes and other tissues. So you need to be careful. Hepatitis B surface antigen may disappear after some time but may continue. Hpv DNA also sometimes disappears, may continue. But what is important is the integrated, what Professor Chabla was discussing, cccDNA. It may stay in some of the tissues, including spleen, monocytes, and other areas. So you have to be careful that even after transplant, you need to look into the patient blood profile for recurrence. We have almost 20 odd patients who were negative. The donor was negative and post-transplant showed activity of Hep B. What is the need of transplant? This slide is important. Liver failure is failure of liver regeneration. You cut the liver, you damage the liver, it has to regenerate. If the damage is more, regeneration is less, it is liver failure. So these are the different terms used for liver failure. A normal liver, healthy liver, gets an acute insult, virus, drugs, he gets acute liver failure. A patient with cirrhosis already has ascites, jaundice, he gets another insult, let's say drugs, corona, something. He becomes further worse. He gets sepsis, bleeding, acute kidney injury, encephalopathy, sepsis. This has its own natural history. Suppose there is F3, F4 fibrosis, NAFLD, he gets an acute insult. Or there is already known cirrhosis, hepatitis B, C, alcohol, cryptogenic, he gets an acute insult. What can happen? This patient can have bleeding, ascites, encephalopathy, hepatorenal. All of them can be a cause of further complications. But if the patient gets liver failure due to cell death, jaundice, and followed by ascites, this is called as acute on chronic liver failure. What is chronic? Chronic is chronic liver disease, compensated cirrhosis. What is liver failure? He gets jaundice and ascites. With this definition, what is under ARC, APSL, ACLF Research Consortium, and of which Professor Chawla is a part, we have a very homogeneous group. But if you take all these patients, then you may have 27 definitions. Why I'm telling you, this is related to our hepatitis B and C. So a patient of hepatitis B has a flare. He is jaundiced, he is deeply icteric. If you do not give him antiviral, let's say this, placebo, the chances that he will live 60 days to 2 months are 20% only. You give him tenofovir, his chances of living 2 months are about 55% or so. His DNA must decrease by 2 logs, then the survival is there. If you can't decrease DNA, he may die. Now, this is the current algorithm for liver transplant in hepatitis B. So, a patient has come who has a flare of hepatitis B and gets acute on chronic liver failure, means jaundice, coagulopathy, ascites within 4 weeks. And MELD is the model for end-stage liver disease. This is a score based on bilirubin, creatinine, and INR. If it is above 30, he needs transplant. No doubts, no debates. If the patient has less than 20, in some studies 23, you give him antivirals. I showed you give tenofovir, he may survive. Between 20 and 30 is a gray zone. So you can stabilize the patient and then decide about transplant. However, if the patient has cirrhosis, bilirubin is about 20, INR is low, DNA does not decrease with tenofovir or entecavir in 2 weeks, platelets are less than 100,000, he will need a transplant. How do you manage? You have to assess. This is the ARC ACLF score. So if a patient has a bilirubin about 20, he is in HG, he has coagulopathy, his lactate is high, his creatinine is high, this patient will fall into category C or grade C liver failure. His score will be 315. He will die. He needs a transplant. So let's see the relevance of this. A patient has an ARC score of less than 10. You wait for a day, 2, 4 days, 7 days. If in 7 days the score goes from 8 to 9, what is 8 to 9? Let's see. He was having bilirubin of 12, it became 22. His score goes up by 2. So if his score goes up by 1 unit, mortality increases by 5% at day 7. But if it's already, like in our patient, 13 or 15 score, 1 unit increase, his mortality increases by 20%. What does it mean? A patient with acute hepatitis B liver failure, reactivation, if he comes to you with this score, he needs a transplant in 7 days' time. So what are our protocols? A patient comes with acute and chronic liver failure. He has the virus. We will give him tenofovir. Of course, our alcohol is steroids. And while he is waiting, we can give him plasma or liver dialysis as a bridge therapy. And definitely will remain in liver transplant. So this is the management algorithm for acute and chronic liver failure before I go to other diseases. So he comes to us, if he has sepsis, you stabilize. If his MELD is above 30 or ARC is above 10, this guy goes straight for transplant within a week. Suppose while you're waiting, you have given him some supportive care, he improves, you can give medical therapy. But if it doesn't improve, emergency transplant. But if he already has lung, kidney, brain, other failures, this patient will need plasma exchange or artificial liver support like Mars and others, and then you stabilize him. He can go and then get an emergency transplant. But if he is not improving, tell him nothing can be done. On the other hand, if he has multi-organ failure, just supportive care. Now, second part of hepatitis, viral hepatitis, and the need for donation. Suppose in India, 20% of the whole population has once been exposed to hepatitis B. So now they don't have HbSAg, but their antibody against core antigen is positive. This is called anti-HB core positive grafts. I just want to tell you, we need many, many people who are doing organ donation or they want to give for their relatives. So the problem comes when you have a donor there is a donor who has a antibody positive graft. Can he give to somebody or not? Yes, he can give it to a recipient who is also positive for the antibody, but also positive for surface antibody. These are patients who had hepatitis B, but these are called self-exposed and immunized. So a hepatitis B donor, if he is core antibody positive, HbSAg is negative, he can give to a person like this without any problem. However, if he gives it to others, you may have to give H big and other. This is just to tell you that you can start these donations and accept them. Let's go to hepatitis C. There is no vaccine for C, and we need to be careful, but it is very easy to treat, like cutting nails from a nail cutter. Liver transplant was the most common indication. Hep C was the most common indication for liver transplant in the past. After, am I audible, please? Sorry. Is my voice audible?
Sir. Yes, sir.
Okay, there was some disturbance. After availability of directly acting antivirals, the transplant numbers have almost reduced to half. And this is because these drugs are very effective. And liver cancer also as an indication for transplant decreased. This is to show you 2018, this is the data. Hepatitis C is seen with the blue. So it was amongst the common causes for in the US for transplant. Gradually it is coming down. What is increasing is alcohol and other causes. So availability of good drugs can decrease need of transplant. These are data also to show you up to 2020 that hepatitis C, which was a common cause for transplant between 2001 to 10, is now decreasing as a cause for transplant. On the other hand, NASH or fatty liver disease is taking a major chunk of transplants. Now, when you want to take a patient with hepatitis C, what will you like to do? Pre-transplant, you will take up somebody who has got cirrhosis but liver cancer. Or decompensated means ascites, jaundice, bleed or encephalopathy. but MELD is less than 20. Model for end-stage liver disease is less than 20. Even then, between 18 and 20, you can take it. You will certainly like to take somebody who is decompensated, has liver cancer, but he must get early liver transplant. All these patients, while they are waiting, you will start antiviral. Hepatitis C drugs have to be started. And patients with access to live donor also should be started. So what is the message? Like hepatitis B, where we start nucleoside analog, we also start directly acting antivirals for patients who are hepatitis C positive and need a transplant. However, if the patient has very high MELD, especially about 24, 25, you will transplant first and then give antiviral. Now, this is the slide. I hope you can clearly pick it up. MELD less than 16 means compensated, nearly compensated. You will give them hepatitis C drugs, directly acting antiviral. 1/3 will get delisted. They don't even need transplant. The MELD is between 16 and 20. 12% will get 1 in 10. 1 in 3 will get delisted just within 12 weeks or so. However, if it is a 21 to 25, you may think about by giving antiviral. But if it is about 25, as I said, first transplant, then give Hep C drugs. Now, this is to show you the data 2015 to 18 and 10 to 14. Now, the liver transplant has a better survival also. Not only the numbers of patients requiring are decreased, but also the recurrence of the disease of the infection is less. What happens is you have a patient with hepatitis C. You have not treated him. You have put a new liver. Within 10 minutes, as soon as the blood of the recipient will go into the donor liver, hepatitis C will go all over in the new liver in 10 minutes. So it is much better that you transplant when the recipient is RNA negative, but sometimes you can't. Now, suppose you have a new liver with virus, you will have to start treating it. And this is what the message is here. This is a very important slide. It shows you real life scenario that patients who have hepatitis C have advanced liver disease, cirrhosis. You give them directly acting antivirals, 90% will get sensitive, clear the virus. They will be virus negative, sustained viral response. Now, we normally would stop here. We would like to say that such patients, if they require, you do a transplant. But now you follow up these patients who are virus negative. But you see that in proportion of these patients, when they were followed up, 24% achieved clinical improvement in MELD. When they were followed up, MELD decreased in 3, MELD score decreased by 3 in about 30%. But in the long-term follow-up, a proportion of patients will develop liver cancer. What it means that DA is, even after being given, the blood is negative, the virus stays. This happens in the old liver. Even in the new liver, once the virus comes, treatment is a challenge. So what do we need to do? All right, we have to do a lot of work in this. HCC is a negative predictor of sustained viral response. Means suppose you have a patient with cirrhosis and you have HCC, you will give them therapy. These patients may not really respond. Can we take livers from viremic donors? Now, 34 HCV seronegative recipient means that there were recipients who had hepatitis. My voice is resounding. Do I need to do something else? Okay, I'll continue. So, the message from this slide is that when you give the patients who have viremia, like you have 34 HCV seronegative recipients who received grafts from HCV positive donor. Can we use a donor who is hepatitis C anti-HCV positive, whether he has RNA positive or RNA negative? This is a very important slide. I hope I can explain you. Now, you are using a donor who is anti-HCV positive. Means he may have some RNA, but not detectable. So these were 14 patients. 20 patients were anti-HCV positive and RNA positive. All 20 who received a viremic graft had viremia within 3 days. Means today you get a graft from a hepatitis C positive patient and you will start making the virus in 3 days' time. This is what I said. In 10 minutes, the new liver will get the virus and it will start multiplying. So what should we do? Directly acting antivirals were started within 27 days after transplant. Maybe you can start even earlier, but the drugs have interactions with immunosuppressant. Now, once you started, see the beauty. All 20 patients who had viremia post-transplant achieved sustained viral response for 12 weeks, means virus was cleared in everybody. No graft failure. Excellent short-term outcomes. So the message is, you have a patient, you take a graft from Hep C positive, doesn't matter. You give it to the person who deserves it and then treat him for hepatitis C. So my carry home message on this World Hepatitis Day, please continue on Hepatitis Day activities as you have been doing under leadership of Dr. Vikas and the whole team. But remember, at least for next 2 decades, B and C will remain a major cause of cirrhosis, liver cancer, and would need liver transplant, although it is changing. Nucleoside analogs, tenofovir and entecavir, should be given before and maybe after the transplant in Hep B. In hepatitis C, directly acting antivirals need to be given to make patient non-viremic, but if his jaundice is too sick, you do a transplant and then start DAA. The transplant will be successful. Anti-HBC core positive, prior exposed, can also donate. Their liver cadavers can be taken. Hepatitis C positive donors can also be taken. So your pool of donors should be increased. I do hope AIMS Hyderabad will join hands with Asian Consortium and also sequel surveillance studies. AIMS Hyderabad and ILBS, maybe like any other institute you are partnering, we hope we can have healthy liver, healthy India, seeds of hope can be sown together and we together can make a very healthy country. A very happy World Hepatitis Day to all of you in AIMS Bibinagar inviting me.
Unmute and video on. Thank you, sir, for such a insightful talk with so much discussion about the changing trends of viral hepatitis and the liver transplant. I would like to again thank you, sir, for your gracious presence in our CME and delivering such an important keynote oration. Are there any questions among the audience? For Professor Sareen? I would like to request all the delegates if there are any questions for either of our keynote orators, Dr. Yogesh Chavla or Dr. Sareen, please feel free to type them in the chat box and we would definitely take them up at the end of the session. Sir, we are so thankful to you for taking time out of your schedule to give us this. This is just a token of appreciation from AIIMS Bhupe Varman. And sir, taking the inputs from your presentation, AIIMS Bhupe Varman would definitely like to collaborate with ILBS and ARC institutions and learn from stalwarts like you and Dr. Yogesh Chawla. Thank you for giving us that window of opportunity, sir.
Thank you.
Moving ahead in our CME, the next speaker I'm going to introduce, and I'm humbled to introduce my dear teacher, Professor Pradeep Deshmukh, presently the Professor and Head, Department of Community Medicine at AIIMS Nagpur. So thank you for accepting our invitation and being a part of our CME. Professor Pradeep Deshmukh is an MD Community Medicine from my alma mater, Mahatma Gandhi Institute of Medical Sciences, Sevagram. He's a postgraduate certificate in nutrition and certificate in international perspectives in participatory monitoring and evaluation. He brings to us 22 years of enriched experience in public health with over 115 publications. He has shouldered more than 25 projects in public health. Now I would like to request Dr. Pradeep Deshmukh to enlighten us with the global epidemiology of hepatitis B virus. Over to you, sir. It's used from sharing. Yes, sir. Pradeep, sir, your presentation is visible and you're audible as well.
Thank you. Thank you. Good afternoon, everyone. At the outset, let me thank Professor Vikas Bhatia, Director of AIIMS Bhupe Varman. I will also like to thank Professor Rahul Narang, Professor Neeraj Agarwal, Dr. Vishakha Jain, and the organizing team for giving me opportunity to present this on this World Hepatitis Day celebration. I will be presenting on epidemiology of hepatitis. Sorry, I'm not able to move this slide.
Sir, you're audible, sir.
I'm not able to move this slide. Okay, fine. Slide back. How do I move the slide?
Sir, slide
The slide is
visible,
behind.
sir.
Want to go backward?
Sir, you can use the arrow button.
Yeah. It was not happening with. Okay, I'm able to manage it now. Okay, we know that many viruses cause hepatitis, and majority of the hepatitis is caused by 5 viruses, out of which 2 are waterborne and 3 are bloodborne. And these 5 viruses together caused 1.34 million deaths in 2015. All of them cause acute hepatitis, and hepatitis B, C, and D viruses also cause chronic. We know that chronic hepatitis, few of them progress to cirrhosis, and then out of then few move to hepatocellular carcinoma, which is the commonest primary liver cancer. The Hpv DNA may integrate into genome of the infected hepatocyte, which results in lifelong infection. Integrated DNA fragments may contribute to the development of hepatocellular carcinoma. Non-structural protein, HPX, supports the transcription of viral DNA and may contribute to the oncogenicity. Hepatitis B virus is a worldwide phenomenon, and as per the seroprevalence of HBsAg, we categorize the areas under 4 heads. If the seroprevalence of HBsAg is less than 2%, we say it is low endemicity. If it is between 2 to 4%, then we call it a low endemicity area, low intermediate endemicity area. If it is between 5 to 7%, then it is high intermediate endemicity area. And if it is more than 8%, 8% or more, then we call it highly endemic area. In 2015, global prevalence was 3.5%. And today, 257 million people are living with chronic hepatitis B infection. Highest prevalence has been observed in African and Western Pacific region. 2015, around 9 lakh people died as a result of hepatitis B infection globally. Around 40% of them were due to hepatocellular carcinoma, and around 50% were due to cirrhosis, 10% due to acute hepatitis. Infections acquired in infancy through perinatal or early childhood exposure have higher risk of developing chronic infection. With age, it decreases and then stabilizes at around 5 years of age with 5%. Childhood infections contribute more to chronic hepatitis. It also coexists with other infections like 10% with HIV infection, 10 to 15 with hepatitis C virus, and around 5% with hepatitis D. Coming to magnitude, because of sheer number of our population, 1/3 of the world's infected population lives in our country. Around 1 to 2 million deaths occur every year, and 315 million are the persistent years. The prevalence is around 2.9%, which came down from around 3.7% last decade. And the coverage of birth dose of hepatitis B vaccine is around 56%. This is the worldwide distribution, and you can see it shows distribution of B, C, and BC together, and we can see it is most highly endemic in African and Western Pacific regions. Coming to natural history, around 10% of infected adults progress towards chronic hepatitis, and out of that, around 25% progress to cirrhosis. And out of those who have the chronic, cirrhosis, 20% move to hepatocellular carcinoma. Coming to transmission, exposure of mucous membranes and non-intact skin to infected blood or other specific body fluids is one of the ways of transmission. There is perinatal transmission also from mother to child. Here, the infants born to mothers who are positive for both HBsAg and HBeAg are at higher risk of acquiring infection than those born to HBsAg positive mothers. So, with both of them positive, the transmission risk ranges from 70% to 100%, while only if it is HBsAg positive mother, then the transmission risk ranges from 5 to 30%. Cesarean section reduces the perinatal transmission. HPV transmission can also occur in absence of visible blood, such as sharing toothbrushes, razors, contacts with exudates from dermatological regions, contact with saliva through bile, so on and so forth. Sexual transmission among adolescents and adults, the major route of transmission. Coming to disease, incubation period for hepatitis B is around 75 days. The outcomes of HPV infection depends on host factors such as age, sex, genetic background, co-infections, other coexistent diseases, and concomitant medication. The initial infection may be asymptomatic or may present as acute hepatitis with or without jaundice and result in fulminant hepatitis. Acute hepatitis B occurs in approximately 1% of perinatal infections, 10% of early childhood infections, and 30% of late infections. Late infections means in persons aged 5 years and above. The rate of development of chronic hepatitis B infection is inversely related to age of the age at acquisition of the infection. 80 to 90% among infants infected perinatally, 30 to 50% children infected before the age of 6 years, and in 5% among healthy adults. Chronically infected persons are at higher risk of development of liver cirrhosis and hepatocellular carcinoma. This increases with the coexistence of conditions of progression of liver disease in persons with chronic HBV infection, such as HIV, SCV, HTV, high alcohol consumption, or exposures to alpha toxins. Naturally acquired immunity also there. The most HBV infections are self-limiting and followed by development of hepatitis B specific antibodies. Clearance of detectable HBsAg from blood usually takes a long time. Serological markers of previous HBV infections are in many persons who had not experienced clinical signs of liver disease. There is high degree of cross protection between HBsAg genotypes. Immunity to HPV infection after vaccination is characterized by presence of anti-HBs antibody only. Regarding diagnosis, in addition to many other modalities, RDT is also quite useful, and sensitivity is around 90%, and specificity is around 99%. So it varies from product to product, from company to company. Treatment, it has already been discussed by the very learned speakers. The purpose of antiviral therapy for chronic HBV infection is to reduce morbidity and mortality due to progressive liver disease. It is not curative. It is to prevent or delay the progression of cirrhosis, reduce the incidence of hepatocellular carcinoma, and improve survival through long-term viral suppression. Antiviral treatment in third trimester of pregnancy can lower viral load in women and decrease perinatal HPV transmission from mothers with very high viral load. But WHO still not recommends it as a routine for prevention of mother-to-child transmission. Coming to vaccine, there are 3 vaccines available. All of them are recombinant. All of them are developed using recombinant technology. One is yeast-derived. It is non-glycosylated, which lacks the protein pre-S domain of specificity. The other one is glycosylated, having pre-S1, S2, S-containing vaccine, which is used in Israel among neonates and non-responders to conventional vaccine. The third vaccine is vaccine with more potent adjuvant, which is used in patients with renal insufficiency, and is also licensed in Europe. Efficacy of vaccination is evaluated by anti-HBs antibody concentration, which is to be more than 10 milliunits per ml. A primary 3-dose series induces protective antibody concentrations is more than 90% of healthy infants, children, and adults. Infants who receive the first dose at birth compared to infants who received placebo or no intervention reduces are 3.5 times less likely to become infected when born to HPV infected mothers. So that underlines the use of the birth dose of hepatitis B vaccine. It plays a crucial role in prevention of the disease and the elimination of the disease. Obesity, smoking, chronic disease may result in lower response rate. Impact of vaccination programs has been found very effective. Vaccination programs led to decrease in incidence of hepatocellular carcinoma by 60%, mortality due to fulminant hepatic failure by 76%, and mortality due to chronic liver disease by 90%. Western Pacific region, prevalence of chronic infection reduced from 8% to less than 1% in most countries. 90% of the vaccinated, they remain protected even after 30 years from vaccination. This is irrespective of detectable antibody level. This may be because of the booster dose or the infection to HPV mounts an anamnestic response and protects the individual. It is a very safe vaccine. Only 1.1 anaphylactic event has been observed for million doses, and it is contraindicated only for individuals with history of serious allergic reaction to any of the vaccine components. We need to keep in mind the special groups when we vaccinate, such as diabetes, renal insufficiency, HIV, immunocompromised, travelers, pregnancy and lactation. Pregnancy and lactation is no contraindication for hepatitis B vaccination, and all 3 doses can be given. Travelers, they are at higher risk only because of their high risk behavior, and if need arises, then a rapid schedule can be given, which is like 0, 7, and 21 days, and which is to be followed by a booster dose at 12 months. The other groups, there are different, like we talked about, different vaccines which can be used in such cases, or there are trials where they say the repeat dose of the routine vaccine, the 3 doses, repeat of additional 3 doses will convert additionally, most of them, seroconversion will be there, or the double dose can be given. These vaccination programs are very cost effective, especially in low middle income countries and where the burden of the disease is very high. The cost effectiveness is studies are inconclusive in areas where the prevalence is very low, and they are recommending selective high risk strategies. They say the programs are cost effective with triple elimination strategy where they target HIV, HPV, and syphilis together. Coming to elimination, it is the first chronic disease being targeted for elimination. And for any disease to be targeted for elimination, there are certain preconditions. An effective intervention is available to interrupt transmission of the agent, practical diagnostic tools with sufficient sensitivity and specificity, and humans are essential for life cycle of the agent. And all these three conditions are met by the hepatitis B, and hence it is being targeted for elimination by 2030. The strategy is we have to follow universal vaccination till last carrier is alive, and the antiviral treatments to reduce the viral load among the carrier. The barrier is the multi-generation program is needed. But if we can increase the access to the treatment as targeted in our elimination strategy, then this can reduce to 10 years and we can eliminate the disease in 10 years. So to summarize, it may be a huge task to eliminate the disease by 2030, but certainly we will make a good progress. We will take a huge jump in attaining or moving towards the elimination of the disease. That's all. Thank you.
Thank you, Pradeep sir, for such a wonderful talk. And are there any questions in the audience for Professor Pradeep Deshmukh? I again request delegates, if there are any questions, you may post it in the chat and we'll take up later at the end of the session. We would like to thank Professor Pradeep Deshmukh for his presence, and as a token of appreciation and gratitude, we would like to just a token of appreciation. Thank you, sir, for being a part of our CME. In any fight of elimination or eradication of the disease, diagnosis is of utmost importance, and it is my distinct honor to introduce our young dynamic researcher, Dr. Shilpa Thummer, who is carving out a niche for herself in the world of virology. Dr. Shilpa Thummer is a scientist, being in hepatitis group of ICMR, National Institute of Virology, Pune. She was a part of the COVID-19 response team of ICMR NIV Pune. She has also been nominated as a member of Central Team of Experts to investigate pediatric deaths and as a central team for Zika virus outbreak at Jaipur, Rajasthan. She also was a member of Central Team for Nipah virus outbreak at Kozhikode, Kerala. She has special interest in nosocomial infections, bloodborne viral infections, and antimicrobial resistance, and has numerous publications in the same. Ma'am, can I request you to deliver your session on the point of care and newer diagnostics for diagnosing hepatitis B virus?
Good afternoon to all. Ma'am, I hope I'm audible.
Yes, Dr. Shilpa, you're audible.
Okay, thank you so much. So a very good afternoon to all. First of all, I would like to thank Director AIMS Hyderabad and all the organizers of the CME for giving me this opportunity to present in this prestigious platform where the stalwarts of the field are present. It is indeed my privilege to be a guest speaker on this occasion. So today I will be talking about improving HPV screening and monitoring with special reference to point of care tests and implication to resource limited settings. So at the outset, I would like to draw the attention on the impact of COVID-19 pandemic on the viral hepatitis. What is the price that we might have to pay As we know that the Sustainable Developmental Goals had set ambitious goals of eliminating viral hepatitis as a cause of public health concern by 2030. But unfortunately, due to the COVID-19 pandemic, 90% of the viral hepatitis services have been disrupted. And this current ongoing pandemic, it threatens to throw most countries off their course of elimination. So there is an urgent need to explore new models of care to overcome the access hurdles due to the current COVID-19 pandemic. So if we see the mathematical modeling, due to these COVID-19 related delays in 2020, it has been estimated that there could be around 44,800 cases of hepatocellular carcinoma and more than 72,000 cases of liver-related deaths for the next decade. So the impact of COVID-19 on hepatitis B virus has been multifaceted. It has disrupted vaccination campaigns. It has altered the transmission dynamics. Although there is physical distances have increased, there is restriction on movements, but these exceptional situations, they have led to an increase in risk-taking behavior. Alcohol use and intravenous drug use is there. Additionally, many females are now, they have to deliver at home without receiving the proper antenatal care. So that is also one of the issues being faced. Definitely, there is a decreased diagnostic capacity and reduced access to treatment. So this year's World Hepatitis Day theme is indeed very apt, that hepatitis can't wait, the action can't wait. And as we know that every 40 seconds, one person in the world is dying from the consequences of the hepatitis B virus. So people living with viral hepatitis unaware can't wait for testing. We know that worldwide, the dominant model of lab testing is the centralized lab, where all the analytical processes are automated and we can test a large number of samples in a single go. It also reduces the cost of testing, but this model is not suitable for those patients who are living in resource-limited settings. This is because getting tested in a classic virology lab would require venipuncture. It requires storage, cold storage, infrastructure, equipment, personal training. So this is often unaffordable in low to middle income countries. So there is an urgent need to have alternative models of point of care testing for hepatitis B. So what do we mean by a point of care test? So a point of care test is any test which is performed close to or near the patient, that is where healthcare is provided outside of the traditional centralized labs. These point of care tests can provide qualitative or quantitative determination of the markers of infection within a very limited amount of time. So they are also referred as the rapid diagnostic tests. So these point of care tests can be done anywhere. They could be done in OPDs, ICUs, emergency rooms, and even they can be conducted at the patient's home. So what is an ideal RDT? WHO has the assured criteria which has to be fulfilled to call it an ideal rapid diagnostic test. So the assured is the acronym for affordable, sensitive, specific. It should be user-friendly, robust, and rapid. It should be equipment-free and deliverable. But unfortunately, there are very few point-of-care tests currently in the market which meet all these requirements. So what would be the key benefits of having point-of-care tests for hepatitis B virus? The most important of these would be to engage hard-to-reach communities, to reach remote areas, and also retaining patients in care once we have linked them to treatment. So there are 3 clinical requirements where point-of-care tests are needed for hepatitis B. So we need it for the diagnosis of current infection, we need it to determine treatment eligibility, and for further monitoring. So coming to the diagnosis of current hepatitis B infection. So according to national and international guidelines, we diagnose current hepatitis B infection by detecting the hepatitis B surface antigen or HBsAg. So there are multiple point of care tests available in the market right now. And usually there are qualitative lateral flow immunoassay and they are simple, easy to use one-step tests. We can use different specimen, like we can use the whole blood, serum, plasma, can be used to conduct these tests, and usually the results are available within 15 to 30 minutes. So these point of care tests for HBs antigen can help facilitate triage of people. So we can divert patients to like reference lab after doing these screening tests. But as we know, they have a relatively lower accuracy than the traditional lab-based tests. So although there is an exhaustive list of the point of care tests available for HBs antigen, 3 have been WHO pre-qualified. One is the Determine HBs antigen 2, the second one is the Wikia HBs antigen, and the third one is the SD Bioline. So coming to Determine HBs antigen 2, it is produced by the Abbott Diagnostic Companies, previously known as Alair, and it is one of the most widely used HBs antigen point of care tests. It has quite a high clinical sensitivity of 89 to 100%, but there is a wide variation in the people who are suffering from HIV, who are HIV infected. So here the sensitivity can range from 56 to 100%. Although it could be multifactorial, but it has been said that because HIV patients are taking tenofovir-based HIV regimens, so this definitely suppresses the Hpv DNA and also reduces the titer of HBs antigen. So this is a simple test in which we can use whole blood, or the serum or plasma can be used, and 50 microliters of the specimen can be added, and the results can be read after 15 to 30 minutes. So the storage conditions are also 2 degree to 30 degree Celsius, so it can be stored at ambient temperature, and the shelf life of this point of care test is 18 months. In WHO assessment for sensitivity and specificity done on about 500 samples, it showed a very good, it showed 100% sensitivity and specificity. The second point of care test for HBs antigen is the Wikia, which is made by Biomiru. It has also received WHO pre-qualification. Here we require 75 microliters of the specimen, and the sensitivity is quite good, 99%. So here it's a simple ICT test. We do a finger stick prick is done, or a venipuncture can be done. 75 microliters is taken, and for serum we can take 3 drops and read the results at 30 minutes. Coming to SD Bioline, it is the third WHO pre-qualified test, which requires 100 microliters of the specimen and a very good sensitivity and specificity. So coming to the Indian example of the use of HBs antigen point of care kits. So from 2014 to 2017, the Chennai Liver Foundation, they conducted field screen camps in Tamil Nadu. So 75 camps were set in 14 districts of Tamil Nadu, and they screened more than 18,000 people. After that, these people were screened, and either they were vaccinated and linked, or either they were linked to care. So due to these vaccinations, due to these field screenings, they were able to vaccinate more than 7,700 people during the camps itself, and 162 people with a high viral load were diverted for treatment. Nowadays, we also have the multiplex diagnostic point of care tests, which are highly attractive for low middle resource settings. So in this, we can detect multiple pathogens like HBV, HIV, and HCV could be detected together in a single testing strip, but currently none has been WHO pre-qualified. So if we come to chronic hepatitis B care, treatment eligibility, and long-term monitoring, as we know, the treatment decision is not easy, and it depends on various factors, like most importantly, the Hpv DNA viral load, then the patient age, the liver inflammation, and fibrosis. So currently, the gold standard of doing Hpv DNA quantification is the polymerase chain reaction platforms, which is done. But it requires a high manual input, and also there is an accessibility barrier. It cannot be done in remote or resource limited settings. So for hepatitis B DNA quantification, the near point of care solution is the GeneXpert HBV viral load assay. So as we must be aware, this is widely used for tuberculosis also, the GeneXpert instrument. And this is a rapid molecular test, which is cartridge-based real-time PCR assay, in which HBV DNA quantification is done in less than 1 hour. So it is a near point of care solution that we have. But still, these expert facilities are expensive. The instrument itself is expensive. It requires an uninterrupted power supply, and plus it does require training. So it has also been evaluated in India by the ILBS, the Institute of Liver and Biliary Sciences in New Delhi, and they tested archived samples on 3 PCR platforms, on Abbott, Roche, and the Expert HBV assay. And they found very good sensitivity of 97.5% of the expert and specificity of 100% in comparison to the standard methods. So the study concluded that it has a potential for near point of care molecular testing and an excellent performance, and it is reliable for HBV DNA quantification. Then we have the enzyme alanine aminotransferase, which is also used as a key marker for the liver inflammation. It helps in determining treatment eligibility, and also in the guidelines it is given in resource limited settings where HBV DNA testing is unavailable. Treatment may be initiated if the ALT levels are persistently high. So currently one of the most important kits that we have is the BioPoint ALT1, produced by Nanjing BioPoint Diagnostics. It is a semi-quantitative point of care test, and it specifically detects the liver-specific ALT1 protein. So we have 2 isoenzyme, ALT1 and ALT2. So ALT1 is specific for the liver, and ALT2 is also found in the heart and skeletal tissues. So in this test, we have 3 lines. One is the control line, one is the reference, and the test line. So the reference line is actually, it represents 40 units per liter of the ALT enzymes. So it is quite specific, and it has a good sensitivity of 94%. Now coming to dried blood spot. So this is not a point of care test, but it is a sampling method. And it is very useful for mass screening, in which a single finger prick can be taken from a person, and the blood sample is collected directly on a modified paper card, or it's a special kind of a filter paper. It can then be transported to the reference labs at ambient temperature. It does not require dry ice or any special equipment or storage conditions. So it is non-hazardous, and it can be even transported in normal mails. So, and it has a long shelf life. So seeing the utility of dried blood spots, the WHO guidelines, in their 2017 guidelines, they have even recommended dried blood spot for doing the serology HBs antigen or the nucleic acid testing HBV DNA at places where there are no facilities to collect the venous samples, or in case RDTs are not available for doing the HBs antigen, or a person who is having poor venous access. So dried blood spot could be an invaluable tool for large-scale screening for viral hepatitis, and also taking the treatment decision. So this is just the comparison. So the possible organization of combining rapid diagnostic tests and dried blood spot could be, we could collect a blood sample at a peripheral center, and then we could do the rapid diagnostic test. And also parallelly, we can send the sample, the dried blood spot which is collected on the filter paper, can be sent to a reference lab for confirmation and further testing. So we can link more patients like this to care and necessary action. So the cost effectiveness of using point of care test for hepatitis B, it has been seen to be very cost effective in community-based approaches, especially in resource limited settings. And we can integrate low cost HPV point of care test into the existing healthcare services. So like we could include it into antenatal screening, blood donor screening, or HIV clinic. So this could be a solution to achieve a scale up of the HPV testing. But definitely these point of care tests, they need a lot of validation, and more studies need to be done clinically to see how much they are actually effective on field. The limitations of point of care test would be the reduced accuracy compared to the standard test. As already discussed, they do have a very wide variation of sensitivity in HIV infected patients. Also, these point of care tests to receive the WHO pre-qualification, it is quite a slow process. And the novel testing platforms like Gene Expert, they are quite expensive. So currently the need of the hour for point of care test is we need to validate them across populations and across specimen types to see how effective they are actually in detecting any specific marker of infection. And the testing policies should be updated. The health organizations which are already in the fight against viral hepatitis, they should provide recommendations how to use the point of care test, how to select the right test, and where and how to deploy these technologies in relation to existing tests which are there in a specific country. So those guidelines are needed. So before I conclude, one question which we may face in the future would be that do we really need to do the viral load testing for HPV? In a recent study by Shimakawa et al. In Africa, they made a simple algorithm known as TREAT-B, that is treatment eligibility in Africa for the hepatitis B virus. So in this, they compared both the reference guidelines, which are the standard international guidelines, and they also try to identify certain markers that could help in forming a simple algorithm for the patient to be eligible for treatment. So in this, after the HBs antigen screening, what they suggested was for low-income countries which have limited access to PCR, we just need to do two tests, ALT and HBe antigen. So they made a simple scoring. So if the ALT is less than 20, it is 0, 20 to 39, it is +1, 40 to 79, +2, and more than 80, it is +3. And HBe antigen, if it is negative, it is 0. If it is positive, it is +1. So according to this algorithm, if the score of the patient is more than 2, without the need of any liver fibrosis indices, without the need of any Hpv DNA viral load testing, the patient can be easily started on antiviral therapy. So this was initially for the African population, but it has also been tried in different populations, like it has been tried in Vietnam, and it had shown a very good sensitivity of more than 90% in comparison to the reference guideline. So we may need to incorporate such updated or simplified algorithms for resource limited settings. So in conclusion, I would just like to say that we really need to scale up screening of HPV in high-risk population, especially given the COVID-19 related delays. We need to reconsider current models for screening and diagnosis. And point-of-care tests could be an excellent tool for mass screening in community settings, and they can reduce the care cascade because we can get the results of the test at the same time. Within 30 minutes or so, we get the results. So the same day test and treat strategy can be applied. So employment of point of care tests and innovative diagnostic is absolutely necessary for achieving the hepatitis B elimination goals. I would like to acknowledge Professor Priya Ibrahim, Director ICMR NIV, and Dr. Kavita Lole, Scientist F and Group Leader, Hepatitis ICMR Pune. Thank you so much.
Thank you, Dr. Shilpa, for such a precise and informative talk. Are there any questions from the delegates for Dr. Shilpa? Thank you, Dr. Shilpa, for being a part of this CME and taking up such an important topic of point of care tests and newer diagnostics, which will go a long way in the fight of elimination of hepatitis B. As a token of appreciation to you, we would just like to give this. Thank you, Dr. Shilpa.
Thank you so much.
It's a privilege to introduce our next speaker, Dr. Bhupe Varman, an associate professor and sub-dean ethics of NIGRIM Shillong. Sir is a passionate medical educator and is a resource faculty for medical education and training. He has special interest in infectious disease, vasculitis, and critical care, and has more than 90 publications to his name. I would like to request Dr. Bhupe Varman to kindly deliver a session on current therapeutic strategies and guidelines for HPV infection. Sir, you will have to unmute yourself, sir. And sir, are you going to share your presentation or should we share your presentation?
I'm going to share.
Okay, sir. So we can see your presentation, sir.
Okay. Good afternoon. Can you hear me? Am I audible?
Yes, so we can hear you as well. We can see your presentation, sir.
Okay. Good afternoon, everyone. Especially Professor Vikas Bhatia, sir, Director, Hyderabad AIMS, Professor Rahul Naran, sir, Dean, AIMS, Professor Nirag Agarwal, sir, Medical Superintendent, and especially Dr. Vishakha, another organizing committee, and good afternoon, Yogesh Savla, sir, and Professor Serin, sir, for your wonderful lectures. It's like, I think for the audience listening to a teacher in the classroom, it's not like online class, online lectures. It's like listening to a teachers. So good afternoon, everyone. To be very honest, I'm not a hepatologist or a specialist in hepatitis. I'm working in a tertiary care hospital in Northeast India. But as you know, this Northeast India is hub for hepatitis B and C. And I think if you go by population study, especially in the Arunachal Pradesh, almost 80% prevalence was there in one time. And in our center, we get patients from all Northeast countries. So we do have patients of hepatitis B and C. And what we have seen in the last 5-6 years of our experience, there are many genetic diversities are there. I mean, I have my data of around 150 patients of hepatitis C, and we are getting quite a good number of patients of genotype 6, which is not very common in other parts of the country. So I would like to take the opportunity to request Serin sir and Yogesh sir, if you can include Northeast region in your hepatitis projects. You could have some more genetic variation or genetic diversity in your data. And being a government institute, we are ready to incorporate with you, sir. With this, I'm going to start my topic. Contents of my topics around brief introductions. There are different phases already discussed, and we'll just give one brief treatment overview. And in some special categories, like in chronic kidney disease, with co-infection, with in pregnancies, and how to approach. And there are some unresolved issues and unmet needs there. So, despite the availability of preventable vaccines and potent antiviral drugs, hepatitis B virus is still one of the most important cause of cirrhosis as well as hepatocellular carcinoma, causing millions of deaths every year. It's a DNA virus which primarily infects the liver cells, and it's not Virus per se is not cytopathic, but it's a host immune response, how it behaves, that ultimately leads to fibrosis, liver inflammation, fibrosis, or cirrhosis. As Professor Saula sir already mentioned, it was data from 2015. Now it is around 290 millions of people are living with chronic hepatitis B globally, with almost 1 million of deaths annually. In India, also around 42 million people are living with chronic hepatitis B, and every year almost more than 1 lakh of people are dying due to hepatitis B related complications. This slide already it was discussed. And going for the serological markers, what we have to remember from this slide is there are 3 things we have to do. Once we suspect hepatitis B patients, first thing we will go for hepatitis B surface antigen, which is a hallmark of infections. If hepatitis B surface antigen comes positive, then next step will go for hepatitis E antigens, which is the marks of active infections, or which the signs of active inflammations. And then we'll go for hepatitis B Dna. And other things like anti-HBs antigen and anti-HBc antibody. These are the antibody to HBs antigens in normal day-to-day routine practice. In OPD practice, we do not advise. Maybe for some research purpose, we may ask to look for antibodies, and especially as Sirin sir was saying, like during liver transplantation and all, you have to see the antibody in those group of patients we may ask for. And regarding anti-HBc antibody, there are 2 types, IgM and IgG. In some patients, if you are having strong suspicion for hepatitis B and surface antigen negative, there is a window period. In that period, we can ask for anti-HBc to look for active infection. So immunologically, there are 5 phases of chronic hepatitis B, although in clinically we divide in 3 phases. One is immune tolerant phase, then immune activation phase, and another one is remission phase. That immune activations, it may go to pure immune activations, raw replications, and reactivations. In immune tolerant phase, there will be patient will be positive for HBe antigen. DNA level will be high, but his LT level will be around normal range. In immune activation phase, patient will be HBe antigen positive, DNA level will be high, and his enzyme also will be in the more than upper limit of normal value. The raw replicative stage, this will come down, but it will not come to totally normal. Reactivation, again, there will be increase everything, ALT, HBs antigen, and here you can do the anti-HBe positive. In remission stage, there will be this inactive or resolve stage. I'll discuss again these things during my treatment part. Regarding progression and complications of chronic hepatitis B. Once the progression to chronic infection, it depends on how the patients got the infections. Suppose if a baby got infected from the infected mother, then chances of growing infection, chronic infection is very high. It's almost 90%. And the persons got infections during adulthood around 20s, 30s by some other routes like IV drugs, percutaneous, sexual, then chances of chronic infection is less than 5%. So one persons develop chronic infections, they progress to either cirrhosis or to the hepatocellular carcinoma, and sometimes without cirrhosis directly to the hepatocellular carcinoma. And they'll end up with decompensated liver failure, leading to ultimate option once patient develop decompensated liver failure is liver transplantation. Unfortunately, especially in Northeast, we don't have facility for liver transplantations. We have to go for only conservative management. Second issue was financial constraint. Most of the patients, they cannot afford for liver transplantations. So most of the patients, especially in our setup, we have to face the ultimatum death. They died due to some died due to massive upper GI bleed, and most of the patients they died due to hepatic encephalopathy. The goal of the treatment, as it was discussed by Sharon sir and Saula sir, is the clearance of hepatitis B infections. And as sir was saying that there are three groups of cure is there. One is complete cure, one is functional cure, one is partial cure. Although our target is to have complete cure, which is almost impossible to get. So functional cure is the we are trying to achieve. And why it is important to have complete cure? Because it has direct correlations. Like if you can decline the HB surface antigens, and it has socio-immunological response. And with clearance of hepatitis B surface antigens, there is decreased rate of cirrhosis and hepatocellular carcinoma, and definitely there will be increased survival. Coming to treatment, there are two treatment options. One is interferon-based, other one is oral agents. In the interferons, to start with, we had interferon alpha, and then it was modified for a long-acting pegylated interferon. Initially, it was used for hepatitis C, then it was started to be using in level B, hepatitis B also. Till that, we are having 5 oral agents which directly inhibit the reverse transcriptase. Lamivudine was to start with, followed by adefovir, then entecavir, telbuvudine, and tenofovir. These are in the historical development of hepatitis B, starting with hepatitis B surface antigen, then vaccine, then in 90s, interferon, almost a decade it runs with interferon. That then comes lamivudine. Then ultimately in around 2005, we had PEG interferon and one of the most potent antiviral drugs, that is entecavir. Followed by in 2008, we had another potent antiviral drugs, that is tenofovir. Regarding interferon, it was approved in 1992. Initially, it was used for immunocompetent adult patients which are HBe antigen reactive and those who had histological evidence of chronic hepatitis. The dosing schedule was to give subcutaneous daily dose at a dose of 5 million unit or 10 million unit twice 3 times a week. And results of 16 weeks data have shown good reductions of DNA suppressions, almost 1/3 of patients, seroconversion in 20% of patients, loss of HBs antigen in 8% of patients. But the problem is most of the patients, they actually cannot tolerate interferon, even the pegylated interferon, because of its side effect. I have personal experience with treating hepatitis C patients when DA was not available. Most of the patients, because of flu-like symptoms and then bone marrow suppressions, thrombocytopenia, and once you give the injections, next 2 days he used to be bedridden. By the time he recovered, that second dose comes. So basically, for whole duration of treatment, he has to be homebound. So that compliance was very poor, and you cannot use in immunocompromised patients. You cannot use in decompensated cirrhosis patient. Then comes the lamivudine. It was a good drug, especially can use both in especially with co-infected patients. Only problem with lamivudine was the resistance. It's a very high group of resistance. Even with first year of use, we had almost 1/3 of patients, they do develop resistance. And if you continue to use for 5 years, there will be 70% of resistance. If you see the results of 1 year therapy, the DNA suppressions in E-positive patients around 40% and E-negative patients around 60 to 70%. Hepatitis E antigen conversion was noticed around 20%, which increased up to 50% if you continue the medicine for 5 years. Histologic information noticed around 50% and 60% both in E and positive and E negative respectively. Enzyme normalization was noticed around in 70s and 80s with minimal loss of hepatitis B surface antigens. But because of high resistance, it was having good other potent molecule, it was superseded by the other medicines. Next comes Adifovir, dipivoxil. It was approved in 2002. Again, it was used at a dose of 10 milligram per day for 1 year. Not very co-infected with HIV. Again, we are having better molecule like tenofovir. So this molecule also was superseded by other drugs. Pegylated interferon available in two brands. One is alpha 2A and alpha 2B. This one also is to give subcutaneous injection once in a week. Normal interferon you have to give daily. This one you have to give once in a week. So compliance is slightly better. Results as per DNA suppression, hepatitis E antigen conversion, histologic improvisations, enzyme normalizations are as per with other oral antiviral drugs. But if you see the loss of HBs antigens, it goes even up to 12% after 5 years of 1 year treatment. Here, one point to be highlighted is normally we do not do genotype routinely in patients with hepatitis B. But suppose if one think of giving pegylated interferon for hepatitis B patient, then testing of genotyping may help because genotype, there are 10 genotypes from A to Z. And as Salva was saying that genotype A and then B is common here in India, and genotype A response is far better than the other genotypes. So genotype testing may help if you want to start pegylated interferon for the patient with hepatitis B. It is a time frame therapy. It will continue only for 1 year. The cost is issue. Per injection comes around in Indian cost around 4,000 to 5,000 per vial. So cost was one issue and the side effect. Entecavir, one of the most potent drug for hepatitis B. It's available as 0.5 milligram per day. If you see the data of the 48 weeks, it's quite a robust, impressive data. DNA suppressions even may go up to 90%. HBE seroconversions 30 to 40%. Histologic improvement almost 70%. Normalizations of enzymes noticed in around 70s to 80s. And although less, but a good number of cases can have loss of HBs antigens. Resistance, very negligible, reported 1.2% at the rate of 6 years. Another good point, you can use even in patients with chronic kidney disease at a modified dose. Normally, we use every alternate day or maybe twice in a week or once in a week dose. But one should not use entecavir monotherapy in patients with co-infected with HIV. Approved in 2006, but it was not marketed widely because of limited data and against because of resistance and other molecules with less resistance and good recovery rate. Tenofovir, one of the most commonly used drugs for hepatitis B, available as 300 milligram per day. Again, data from 48 weeks of therapy, 1 year of therapy, shows very good results with DNA suppression of around in positive patient 76% and negative patients up to 93%. HBE conversions up to 40% in 5 years. Histologic improvement around 70% is both hepatitis E positive as well as negative patients. ALT normalizations 68 and 76% both in positive as well as negative patients. Loss of HBs antigens. It's better than entecavir, 3% in 1 year, 8%, 8 years. Resistant nil, and another other good point of tenofovir is you can use in pregnancy. It's a B category drug. All other drugs are C category in pregnancy. So in pregnancy, you have to give, if you have to give drugs for hepatitis B, tenofovir is a drug of choice. In patients with chronic kidney disease, these are two group of drug, two group of patients, special group of patients wish to see. One is pregnant lady, one is another CKD. So in pregnant lady, we give tenofovir, and in case of CKD, we prefer entecavir. Combination therapy, initially it was used with lamivudine and peg interferon, no better result than the monotherapy. Then people have started trying entecavir plus tenofovir. Again, in normal patients, reductions are almost same as per entecavir monogroup, but only recommendation of combination of tenofovir and entecavir is those group of patients who are having multi-drug resistance. In those cases, then combination of entecavir and tenofovir may play a role. These are the novel antiviral. First one is not actually novel antiviral we are using now, tenofovir alafenite. It is available as 25 milligram per day. As per literature, advantage of this over originator tenofovir is it has less reduction of bone marrow density and slightly safer in CKD patients than the innovator tenofovir. There are other molecules which are in the pipeline in different phase 1 and phase 2 trial. That is viral entry inhibitor, nucleic acid assembly inhibitor, HBV secretion inhibitor, immunomodulator like toll-like receptor antagonist, T-cell vaccines, then cccDNA inhibitions, RNA interference, HBx inhibition. These are all different innovative drugs which are still under the pipeline in different phase 1 and phase 2 trial. So this is the most important slides or recommendations for hepatitis B treatment. So we are keeping two group of patients. Suppose patient is HBs positive. These are all HBs positive patients. HBs positive patient, and we have done HBe antigen, and HBe antigen is positive. Patient is non-cirrhotic and is having chronic hepatitis B. Chronic hepatitis B, by definitions, the duration of hepatitis is more than 6 months. That means persistence of hepatitis B surface antigen more than 6 months is defined chronic hepatitis B. Now, patient with chronic hepatitis B along with positive E antigens, what to do now? So next test, we ask for the simple enzyme, that is ALT. That is normally we can do in normal day-to-day practice, LFT. Now, if ALT value is more than 2 units of normal, what is the upper level of normal? In the average, in male it is 35, in female it is 25. So if ALT value is more than 70 in case of male or more than 50 in case of male, go for Hpv Dna titer. Or maybe as Shilpa was saying, if facility is not available, and if you can rule out other causes of raised ALT, this group of patients, but as per till now, as per guideline, you have to do the Hpv Dna. Now ALT also more than 70 or 50, DNA also is more than 20,000 count. These are the group of treatment. These are the group of patients we have to treat. Now, ALT value is high, but HBV DNA value is around 2,000 to 20,000. Then we repeat the ALT within 3 months. You see the value of ALT. Suppose it was around 40 initially. Now it's going towards 60s. If it is value is increasing, then immediately you have to start the treatment. Or if you have the facility for fibrosis, fibroscan, or suppose you are having facility for the liver biopsy, if score is more than F2 in fibroscan or more than F3 in the liver biopsy, straight away you can start treatment in this group of patients. Next group of patients, liver enzymes in between. That is, in case of male, it is more than 35 but less than 70. And DNA value also high. Those group of patients, repeat the ALT, see the value. If there is persistent raise, start treatment, or otherwise do the fibroscan or liver biopsy. If you don't have fibroscan, you can go for upper scoring, FIB4 scoring from the simple blood test. They directly correlate with the fibroscan. If there is evidence of fibrosis, then you treat this group of patients. Last group of patients, ALT is absolutely normal. E antigen positive, surface antigen positive. DNA value is high. Again, repeat ALT every 3 months and see the rising trend of ALT. If there is rising trend of ALT, definitely you have to treat. And in this group of patients, you have to monitor DNA value also. In this group of patients, again, monitor HbE antigens every 6 to 12 months. In the second group of patients, if enzymes are in between, then DNA value is again in between. So those group person also you have to monitor the ALT. So in very simplification, if you go, patient is HbS antigen positive, go for HbE antigen, HbN antigen positive, go for ALT. ALT is more than 2 times normal, DNA value is high, no controversy, start with the treatment. ALT is borderline, DNA value is high, go for repeat testing after 3 months. If there is second value is higher than the previous value, start with the treatment or go for fibroscan or liver biopsy. Third group of
Yeah, presenting problem with you.
I'm happy.
Sorry,
those are second group of patients, their HbS positive for 6 months, you label him as a chronic hepatitis B. Now they are HbE antigen negative, but their enzymes are high. Again, it's more than 17 case of male, more than 15 case of male. If enzymes are high, although they are HbE negative, do the Hpv Dna value more than 2000, here it is value is more than 2000, then no controversy, immediately treat the patients. In other group of patients, follow the ALT every 3 monthly. If ALT value started rising, again you have to start the treatment. Or if you are having facility to go for fibrosis, fibroscan and elastography or liver biopsy, then you can go for it. But always you have to remember to rule out other causes of raised ALT in patient with hepatitis B, because most of the time it's the alcohol, not the hepatitis, which can cause raised ALT. Now there are group of patients where we have not started antiviral therapy, like immune tolerant patients, inactive patients, or resolved patients. Like immune tolerant patients are those HbE antigen positive, high DNA value, but normal enzymes. Inactive group of patients, they're all normal, basically. E antigen negative, normal ALT, but they're only HbS positive. And resolved one is HbS is lost. So recommendation in the immune tolerant group is every 3 to 6 monthly, we have to monitor the ALT. And sometimes based on the patient's conditions, you have to monitor frequently. If patient's ALT level increases, you have to start medicines. For inactive patient also, you have to monitor ALT and Hpv DNA every 3 months for first year. Then maybe later on you can increase the gap to 6 to 12 months. And if ALT level increases, if they go for reactivation phase, you have to start the treatment. If patient got HbS loss, luckily patient has HbS antigen negative, then no need to monitor for ALT and DNA value. But here we have to look for HCC surveillance, as Saula sir and Serin sir was discussing. that you cannot clear the cccDNA from the hepatocytes or from other cells. So small numbers of cccDNA will be there. So surveillance for hepatocellular carcinoma has to be continued, although patient achieve its loss of hepatitis B surface antigen. So what to start? We are having option for 4 drugs: entecavir, tenofovir, efetamide, and pegylated interferon. So these are all high potency, high genetic barrier drugs. As I have said, entecavir is better choice for. They are all almost equally effective. Entecavir is slightly better choice in CKD and tenofovir is better for. Yes, madam.
Can I request you to hurry up a little as we are at time
I'm just
constraints?
about to. Yeah.
Yeah, thank you, sir.
In hepatitis B virus in pregnant lady, this one, all infants of hepatitis B surface antigen positive women should receive immunoprophylaxis. Only antiviral drugs studied. These are option is tenofovir already I have discussed. Antiviral therapy started at 28 to 32 weeks of gestation, and it has to be discontinued for 3 months, and then you have to follow up with the ALT. In patient with chronic kidney disease, as I have discussed, tenofovir is the entecavir is the option. Actually, we can give in alternate day or weekly basis. HCV and HBV co-infection, we have to start medicine for both regardless of CD4 count. ART should include 2 drugs which are active against hepatitis B, that is tenofovir plus either lamivudine or imitacitabine. If patient already receiving ART, then you have to incorporate these drugs in the ART regimen. Acute symptomatic hepatitis is characterized by bilirubin more than 3 mg, INR more than 1.5, and encephalopathy and ascites. Entecavir, TDF, or TF are the preferred drug. Treatment should be continued until HBS clearance is confirmed or indefinitely in those who undergone liver transplantations. PEG interferon is contraindicated. The unresolved issues are when to start antiviral patient are HB negative, when to stop the medicines, retreatment after discontinuation of oral drugs, and how to screen for the risk for hepatocellular carcinoma. The need of hour is the new treatment with finite durations and high cure rates, how to define cure of HBV infections, definition of novel endpoints, biomarkers for the cure of infections and for the cure of liver disease. Thank you. Thank you very much. So Shillong is known for scenic beauty. This is known as double-decker ring road bridge. It's almost 3,500 steps down from the hill. It takes almost 3 hours to reach there. And once you cross this double-decker bridge, this is Living Road Bridge, then you'll get one Rainbow Falls. And to come back, it will take almost 5 hours. So it's almost 9 hours journey from on foot. You have to go almost 3,500 down steps. So once you visit Shillong, comes and enjoy this scenic beauty of Shillong. But you have to be physically fit to go down and to come back almost 3,500 feet. Thank you very much.
Thank you, Dr. Bhupe Varman, for such a comprehensive talk on the treatment guidelines about hepatitis B. We would just like to give a token of appreciation for your contribution to our CME. Thank you, sir. Thanks a lot.
Thank you.
Last but not the least, it gives me immense pleasure to introduce my dear friend, a young, energetic, dedicated researcher and hepatologist, Dr. Sahaj Rathi, who's presently working as an assistant professor in PGI Chandigarh. Dr. Sahaj did his fellowship in hepatology from PGI Chandigarh, after which he did a fellowship in transplant hepatology from University of British Columbia, Vancouver, Canada, and a clinical research fellowship from University of Padova, Italy, focusing on nutrition and sarcopenia in cirrhosis and spontaneous photosystemic shunts in cirrhosis. He's well published with more than 40 research papers and 7 chapters in book. I request Dr. Sahaj Rathi to deliver his talk on the treatment endpoints of Hpv disease and treatment of core Hpv disease. Over to you, Dr. Sahaj.
Am I audible?
Yes, Dr. Sahaj, you're audible.
So let me begin by conveying my immense gratitude to the organizers for this opportunity. Dr. Bhatia, Dr. Narang, Dr. Agarwal, Colonel Rao, and especially Dr. Vishaka for giving me this opportunity. And I would like to use this platform to convey my regards to my mentors, Dr. Chawla, under whom I did my DM, and to Professor Sareen, under whom I worked for some time. I have immense regard for these people. And frankly, standing on the shoulders of giants is how we have been able to see Father and these two immensely respected researchers and clinicians who are there today. They are real giants of hepatology in India as well as across the world. So my gratitude. I know I'm the last speaker, so I will not, I'll come straight to the topic. I would like to keep this presentation short because, first of all, I understand that, we are all tired.
We can't see your presentation. Share it.
All right, so let me share my presentation. Is my screen visible?
Yes, your screen is visible. Yes, we can see
all
it.
Right. So I will be talking about some of the fringe areas of hepatitis B management, ones that are not usually talked about, and that is how to stop treatment, if ever, and how to treat those, isolated core positive diseases. I would keep this short because in some aspects there's not a lot of data, so we'll have to resort to expert opinion. So the agenda of this talk is what are the treatment endpoints in patients who are taking nucleoside analogs? Can we stop these drugs? Why stop in the first place? And in whom can we stop it safely? And what then? And then we'll talk a little bit about isolated core antibody positive, because now we investigate more, so often we get these isolated core antibody positive patients who are referred to us. So what are the implications of this test, and when do we treat them? To begin with, treatment endpoints. So the aim of all therapy that we give is predominantly to control viral replication, which will yield a reduction in liver-related risk, that is reduction in liver failure, reduction of risk of cirrhosis, reduction of development of carcinoma, potentially reducing extrahepatic manifestations like kidney manifestations, and again, to reduce transmission. We also want to increase our patients' survival and improve their quality of lives. If the same aims can be reached without treatment, we may consider stopping in certain cases, and that's what we are going to talk about. So why stop in the first place? Because these drugs are the newer nucleoside analogs that we have, nucleotide analogs, they are very safe, they are very effective, and they have not shown any long-term problems. But we have to keep in mind that we treat most patients in this area, that is when they start developing the hepatitic activity of the disease, and these are young adults, so they are going to have decades of treatment. So we may have to keep in consideration patient preferences. Some patients do not like to be on treatment for so long. We may have to consider cost, especially in India where most of the healthcare is out of pocket. So cost of therapy is a concern. There are concerns about developing resistance in long term. However, those concerns are now much lesser now that we have high genetic barrier to resistance drugs like TAF and TDF and entecavir. But still, the concerns remain. And even though these drugs are safe, because they are going to be given for decades to young adults often, even the rare adverse effects, they sometimes count. So a question should always be raised. Can we take these patients off treatment? So let us look at that. Before that, I know that we have had a lot of talk about hepatitis B today, but I'll just reiterate some of the basics. So there is hepatitis B, the virion is there in the liver, which replicates and leads to complete virions coming into the bloodstream. Some of the particles like HbSAg and HbE antigen, incomplete particles also in the bloodstream. Now, what is this going to lead? This is going to lead to inflammation within the liver and viremia in the bloodstream. What is clinical remission? Clinical remission is when we have DNA less than 2000 in the bloodstream and the necroinflammatory activity within the liver is down to a minimum, which is evidenced by normal transaminases. This is something that we reach very often with the treatment that we have. But is this a good endpoint? No, because the moment we stop the treatment, the patient will go back here. So what is the next endpoint? That is virological remission. What if we are able to take all of the virus out of the bloodstream? Well, some of the virus will still remain within the liver. Some of the markers will still remain in the bloodstream. And while we can reach this endpoint very soon with most of the drugs that we have, this is again not a good endpoint because this can again go back to necroinflammatory stage once the treatment is taken off. We take it a step further. What happens if there is HbE antigen seroconversion? So if we develop antibodies to the E antigen, or we, if not that, then maybe just achieve an E antigen loss. This is somewhere close to where we want to be. So we'll come to that. Functional cure. Now we call functional cure is HbS antigen loss or seroconversion, when we are able to get rid of the get to antibodies to hepatitis B surface antigen, which can clear away all of the surface antigen. Or short of that, maybe just be satisfied with clearance of hepatitis B surface antigen. This is as close to a cure that we can reach in realistic goals. What would be a complete or ideal cure? It would be if we are able to completely get rid of the virus, the cccDNA from the liver, which is the holy grail, but is practically never achievable because the cccDNA is integrated within the genetic makeup of the hepatocytes, and it keeps replicating to some degree. So this is something that we are not realistically able to achieve till date. So now that we know that functional cure of HbS antigen seroconversion, or at least E antigen loss or seroconversion, is where we at least need to be, when do we stop? Who can stop? So the guidelines, they vary, but I'll try to kind of simplify it. So I'll divide it into E antigen positive and E antigen negative patients. So we have three major guidelines that we usually follow. And let's talk about the E antigen positive disease. If we are able to reach in E antigen positive patients from baseline, if we are able to achieve S antigen seroconversion, both EASL and AASLE, the European and the American guidelines, they say go for it. We can stop therapy. APASL guidelines, they are not very forthcoming on this, but it is. I think that this is a reasonable. It is reasonable to assume that this is going to be okay with that as well. E antigen loss on treatment. That is, if the patient has E antigen positive and they lose their E antigen and or develop anti-HbE antibodies, all guidelines say it is okay to stop provided there is at least 1 year, and in the PASL's case, at least 1 to 3 years of consolidation therapy with high barrier to genetic resistance drugs preferably, which will help us to achieve a better outcome in terms of patient stability of treatment. So what in E negative disease? E negative disease is slightly harder to treat, but once an anti-HbS, that is seroconversion, is achieved, all the guidelines are okay with discontinuing. If only seroclearance of HbS antigen is received, AASLD says it's okay to stop treatment with close monitoring. EASL is okay with stopping. APASL guidelines suggest that at least 12 months of consolidation should be achieved before we take the patient off treatment. If the S antigen is still positive and we have achieved only E antigen loss, now these are situations where we would like to be a little more cautious, and all guidelines will recommend caution. A fair duration of consolidation therapy with very carefully chosen patients and a very tight follow-up at expert centers are only the cases where it would be recommended to go off therapy if there is a pressing indication. What if a patient has already developed cirrhosis? Now, this is a contentious issue. Most guidelines will be hesitant, but it can be done if there is an anti-HBs positivity. But if the HBsAg is still positive, that is only an E antigen negative state and anti-HBe positive state, EASL and ASLD, that's the European and American guidelines, they just flat out say this is not a good idea. APASL, the Asia Pacific guidelines, still say that in carefully chosen cases, it may be tried, but most experts, most centers would shy away from doing that. And frankly, WHO recommends that these patients who have cirrhosis should be on lifelong nucleoside analog therapy, should not be discontinued, and this is a strong recommendation from the WHO. There is some new data on why to stop these therapies, except for the 4 points that I have mentioned before. And I'm going to kind of share this with you just to give you a perspective of why this is again a topic of debate amongst clinicians, and that is in patients who have chronic hepatitis, these patients are chronically exposed to hepatitis B virus for a very long time. So normally the T cells, these turtles, they represent T cells. Normally when there is an offending virion, they will normally attack. They will try to destroy the cells that contain the virus. However, because these viruses in most cases have been with the patient for a while, most of the transmission in India is perinatal transmission, and the patient has had this virus for a long time. There are regulators of these T cells, and these regulators will stop the T cells from attacking the virus because they have grown accustomed, they have kind of grown familiar to the virus. Now, if the patients are treated with nucleoside analog, what happens is these T cells, they become senescent with time and they do not attack this virus anymore. Now, what happens is if we treat these patients with nucleoside analogs, the Hpv DNA levels go down, the viral replication goes down, and these cells, that the regulators that have consistently been exposed to the virus, they get a chance to forget that virus. And when now these drugs are stopped, there is a new rise in functional hepatitis, anti-hepatitis B CD8 cells, which now recognize this virus as a problem-causing substance, and now they are able to attack it. It's kind of like an auto-vaccination. So this new viremia that will happen with the nucleoside analog withdrawal, this may lead to a cure. Now this sounds very prudent, this sounds very fancy, that okay, we are able to vaccinate the patient with their own virus, and by creating a viremia, create a kind of an mild controlled inflammatory state, and we may be able to achieve the HBs antigen conversion naturally. That's actually very nice to hear, but practically it happens in a very small number of patients. So despite a long duration of therapy and despite a long follow-up, we can see that 1 to somewhere like 11% is what the HBsAg seroclearance rates are, and this is also kind of an extreme. Most studies say 3 to 4%. So whether it is worth it, that is to be decided based on an individual patient. Now, this is some of the data on what happens when this is withdrawn and the treatment is withdrawn in E antigen positive and E antigen negative patients. In E antigen positive patients, after small consolidation therapies, there are higher chances of seroreversion, higher chances of clinical relapse. Some of the studies that have, used a longer consolidation therapy, some studies say that there are, less chances of relapse and more chances of achieving a cure, but the data is highly, highly variable. In E antigen negative disease, the clinical relapse rates are much higher. So whether this is something worth trying, this is a very individualized decision on a specific patient. That said, one good predictor that we have of being able to achieve a S antigen loss, that is our functional cure, is the baseline hepatitis B surface antigen levels. If the surface antigen levels are very low, there is a high chance that we may be able to achieve a functional cure. So just to consolidate this, what I've talked about till now. So if a patient we are able to take off therapy based on the criteria that have been laid out and based on individual patient assessment, if a patient, we expect some of the disease flare. However, we need to decide whether a flare is beneficial or non-beneficial. If the flare is detrimental, what we call detrimental flare is very variable, but it's not very well established. But in most cases, if the AST, ALT go beyond, say, 5 times upper limit of normal, if the bilirubin rises to more than 1.5, or if there are any severe INR is elevated or any evidence of decompensation, we immediately stop treatment and we start retreating it. So these are the detrimental flares which we do not want. Beneficial flares, when there is just some slight elevation of AST, ALT with not much of jaundice, not much of bilirubin elevation, I mean, maybe we can continue. However, we need to make sure that the disease activity does not last too long. If the disease activity lasts for more than 6 months, we would like to retreat the patient immediately. In patients who do develop some immune reactivation, we would like to monitor them very closely. Liver biopsy, it's a center-specific decision. However, fibroscan can be used to kind of follow these patients up. But again, this needs to be done at expert centers with dedicated short-term follow-ups and very close follow-ups of the patients, because there's always a risk of development of severe flares. Even if the risks are low, they are very much there. So once treatment stopped, if HBsAg was still positive, then close follow-up with expert centers as recommended. But if HBsAg is lost and anti-H has been developed, the patient may require less frequent follow-up, which can increase over, the duration can increase over time. However, as expressed before, HCC surveillance is still a must. And again, patients who are going to be on any immunosuppressive regimen and have had past hepatitis B, they should be followed up very closely, and they may need to be put back on antiviral drugs. Another subset of patients who may need immunosuppressive, anti-hepatitis B drugs in immunosuppressive conditions is patients who are total anti-HB core positive. So I'll now start talking about anti-core positive patients. So isolated core positive is seen in about 8 to 18% of population in the general population. I'll talk about special risk groups in a minute. What we would like to do is we would like to do an Hpv DNA of these patients in the serum. If it is detectable, it is categorized as occult hepatitis B. Now, occult hepatitis B technically is Hpv DNA in the serum as well as in the liver tissue, but we don't check for that regularly. So this is seen in a very small number of patients. Most patients are actually who have core positive in the general population do not have detectable Hpv DNA, and these are the patients in the absence of any other marker we would label as past hepatitis B infection. But as discussed before, the cccDNA, which is integrated into the hepatocytes, can still cause problems. And for that reason, we need to be aware of certain things, in which cases we may want to express caution, or when we may want to treat the patient. So before that, let's just come to the risk factors for isolated hepatitis B core antibody positivity. Areas which have a high hepatitis B prevalence obviously will have more core antibody positive because they'll have more resolved infections. People living with HIV and AIDS, again, these this subgroup will have a high number of anti-hepatitis B core positive antibody, and in these patients, viremia can be much more common. In patients who are hepatitis C positive, up to 37% may have core antibody positive. However, these are not patients who have resolved. This may not be patients who are having resolved infections. This may actually signify now hepatitis C inhibits hepatitis B replication, and these are patients who may actually have had replicating hepatitis B at some time. However, because of hepatitis C interference, the replication part has kind of settled now, and it's only the core antibody positivity that is being manifested now. However, there is a concern that when these patients are treated with DAAs, there might be a risk of hepatitis B flare. This concern was raised at one point of time a couple of years back, 2-3 years back. However, if we look at the data, patients who are HBs antigen negative and do not have occult blood infection with core antibody positivity or or DNA positivity, the chances of flare hepatitis reactivation are actually very low. So that's probably less of a clinical concern. More, this should still be kind of kept in mind, but prophylactic treatment with nucleoside analogs is probably not warranted. However, when we come to immunosuppressive regimens, it may be warranted to treat these patients as a prophylaxis. So whenever using B cell depleting agents like rituximab, these are patients who are having a high risk of flare. Isolated core antibody positivity may have a high risk of flare. Up to 10% patients might actually flare. So for these patients, it may be reasonable to start on a high genetic barrier resistance drug for 12 to 18 months till after treatment discontinuation and monitor them for another 12 months. Now, most of the guidelines actually recommend lamivudine, and that's probably because in the West, lamivudine is much cheaper than entecavir and tenofovir, but in our country, probably it's reasonable to go for entecavir or tenofovir because the cost is not that much higher. In patients who are going to be receiving less immunosuppressive regimens, anything short of full dose rituximab, it may be reasonable to simply monitor these patients at 1 month and then every 3 months with markers of necroinflammation like AST, ALT, Hpv DNA, and hepatitis B surface antigen. If there is any change in the surface antigen status, any development of viremia or rise in transaminases, it may be reasonable to start these patients on nucleoside analogs. One more important thing is if the patient is anti-HB core positive and has anti-HBs levels of say less than 10 international unit per ml, it may be reasonable to vaccinate these patients again. Preferably before, if especially if the elective immunosuppression is elective. So with this, I am going to conclude my presentation. Take-home messages are hepatitis B cure, the true cure in the true sense is extremely difficult and is not a anticipated target. Functional cure is possible, but it is rare even with interferon. I have restricted my talk to nucleoside analogs because that is what we are giving right now. Functional cure is possible, but rare. Treatment may be stopped in very carefully chosen cases, especially when S antigen seroconversion has not occurred. It has to be in very, very carefully selected patients, preferably in centers which have expertise in hepatitis B. Again, the anticipated benefit is limited to approximately 5% cases with a definite, small but definite risk of flare. Consolidation therapy, a long consolidation therapy, at least 1 to 3 years, with a quantitative surface antigen levels preferably less than 100, is probably a reasonable criteria to have before we choose to stop the patients from nucleoside analogs. And among patients with isolated core antibody positivity, immunosuppression, if warranted, may require treatment with antivirals. If the anti-HBs titers are low, then vaccination is recommended. If the patient has cirrhosis along with isolated core antibody positive, it may be reasonable to treat the patient This is not based on data, but probably on expert opinion, that if no other clear cause of cirrhosis is evident and the patient is core positive, it may be presumed that this patient has some degree of viral replication that has led to cirrhosis, and it may be reasonable to treat the patients. I will conclude my lecture here, and if there are any questions or comments, I'll be happy to take them.
Are there any questions from the delegates for Dr. Sahaj Rathi? Thank you, Dr. Sahaj, for a succinct and comprehensive talk on the treatment endpoints and treatment of core disease. We would like to extend our gratitude and appreciation by giving you a token of appreciation. It's actually a token only.
Thank you.
Thank you, Dr. Sahaj. We've come to the end of our CME, and I'm sure that all our delegates would have enjoyed this academic feast. Walking with a friend in the dark is better than walking alone in the light, said Helen Keller. The walk towards this academic event was also a collaborative effort by many dedicated individuals who put in their best in an effort to bring together everything for today. Atithi Devo Bhava is what our culture teaches us. And so I start by offering our deepest appreciation to Dr. Yogesh Chawla and Dr. Shiv Sareen for taking time to grace this occasion and enlighten us with their talk. We would also like to thank our other speakers, Dr. Pradeep Deshmukh, Dr. Shilpa Thummer, Dr. Bhupe Varman, and Dr. Sahaj Rathi for contributing to this CME in a beautiful way. An institution is a reflection of its leader, and ours is a beacon of excellence, all due to our director, Dr. Vikas Bhatia. Dear sir, your guidance, sage advice, and perpetual encouragement makes us to realize our full potential, and we thank you for all this. Professor Rahul Narang, a humble but a driven researcher, is an asset to any institute, and we are fortunate to have him here at AIIMS Hyderabad. Thank you, sir, for your guidance during the course of planning and execution of the event. Our institute is lucky to have the vast experience and solid work ethics of our medical superintendent, Dr. Neeraj Agrawal. Thank you for always being there for us and guiding us through the maze of organizing today's event. I would like to express my sincere gratitude to our Deputy Director Admin, Colonel S.P. Anantrao, a gentleman and an officer of an Indian Army. His discipline and will to get work done in a timely and orderly manner have helped us immensely as we planned and organized this event. Dr. Lakshmi Jyoti ma'am, additional professor and the chairperson of today's CME, was the force behind this event. I thank you, ma'am, for all your efforts for making this event possible and successful. Every academic event has people who are workhorses and without whom the even best laid plan would not work out. Dr. Raja and Dr. Sunil, I thank you both from the bottom of my heart for being the trusty, never tiring and patient colleagues who have done the bulk of work in organizing this event. I thank my head of the department, Dr. Shakti Vadivel, for his constant encouragement and motivation. All others in Department of Medicine and Microbiology have shouldered our work and helped us in ways which cannot be expressed in words. Many nursing officers have been with us, helping us for the seamless CME planning and execution. Naming a few, I would like to thank Mr. Suraj, Ms. Aarti, Ms. Binu, and Ms. Smita for their contribution towards the CME. The event was a virtual mode on WebEx and was broadcast live on the internet to connect to speakers as well as the participants. And this would not have happened if not for the efficiency and help of our IT team. For this, I thank Mr. Bhaskarrao Garu, Mr. Kushala, and the entire team. There would be many who are behind the scenes, and I thank you all for your support. Last but not the least, I would like to thank our delegates for being there and enjoying this academic feast. Thank you all.
Just